privacy without restriction. I think that's very universal. But there are also these that's the interaction of smoothing out makes a little bit more. So generally, this group was protected. How much is including right there are. So, that answers. Research activity afterwards certainly is very likely. Research sports afterwards certainly very likely. As long as you have really opportunity for management of the patients and emphasis on how much hard work after we do. In complex that will return this. Based on angles and so obviously also in fantastic angles there based on the construct even rehabilitation should follow protocol. We have be very clear with patients. Thank you very much.
Thank you. I'd like to thank Dr. Raghuveer Kaka and Dr. Beck Lord for providing us the videos to present in the conference. And I thank Professor Wilson and Dr. Sachin Tapasvi for their talks. And I request them to stay back on the podium for the next panel session. And may I now request Dr. Dinsha Pardiwala to moderate the panel session. And I request Dr. Milind Chaudhary, Dr. Atik Vastev, Dr. Roshan Bade, and Dr. Santosh Sahanan to be the panel members. Thank you.
Are you connecting? I'm connecting on laptop. Just shut this down. HDMI or C connection? Anything. Someone needs to just Okay, so we'll start now with the panel discussion. We've got a very eminent surgeons here in the panel with us, a lot of experience collectively for osteotomies, and I'm sure we're going to get different opinions for these cases. So we'll start off with the first case. Yeah. Just you keep there. I'll just. Thank you. Thank you. Okay, start off with the first case. So this is a 42-year-old male. He's undergone a left knee PCL reconstruction 7 months prior to presentation. He's had a persistent limp with knee pain and severe functional disability. He's limping significantly. He's in a lot of pain. He's got no instability symptoms, but when you clinically, excuse me, examine him, he's got a fixed posterior subluxation with a varus malalignment. And you can see that he's got a sag there, but unlike the standard PCLs which are correctable, this one's not correctable. He's got a fixed posterior subluxation there, and he's had no relief with prolonged physiotherapy. Those are his standing weight-bearing X-rays, both in the frontal and the sagittal plane. That's his AP X-ray there. His MPTA is 79, MLDFA 88. His lateral joint closing angle, joint convergent angle 3 degrees, and his posterior tibial slope is 8 degrees. Again, when you see this, this is X-ray in lateral position, and a lateral X-ray with corrective force. So you can see we can just about get him to correct up to grade 3 or grade 2. And that's his weight-bearing full extension. Again, you can note that the tibia is subluxated posteriorly, and he's not getting reduced. Adrian, what would you do for this?
So very good case, difficult. Obviously, we have significant medial compartment osteoarthritis, looks full thickness. We have a relatively flat slope, and we have a failed PCL with a fixed subluxation. So things we need to address here are we need to try and do something to correct the varus and straighten the leg, and at the same time do something to offload that medial compartment. So for me, I'm not actually an expert with PSI. I think if you were an expert with PSI, maybe you could do a combined procedure where you could actually help this chap by increasing his slope and valgization. For me, this would be an anterior approach. I would do an increased, I would do an opening wedge anterior flexion osteotomy. And at the same time, I would create a little bit of varus and then a valgus. And then as a second stage, I would bring this chap back once we'd corrected his slope. And then I would go for the valgization, the second osteotomy, performing a medial opening wedge.
So you do a 2-stage osteotomy.
Yeah.
And so how much time would you give between the two?
So the anterior opening wedge would take 3 to 6 months to heal. We would obviously use femoral head allograft and we would do asymmetric. So we would create some varization, but I don't think it would be enough. This guy's got significant varus, maybe even requiring double level correction to get that Michelitz line where we want it. He's got a horrible MPTA. But I don't think I could tackle this in one surgery. So for me, this would be 2 surgeries.
Okay.
And I would do it in that order.
Milind, what about you?
If the subluxation is not getting corrected completely,
Correct.
may I hazard that he need a posterior capsulotomy? And then to protect it from recurring into subluxation, I would use an external fixator, which in my hands would very comfortably allow me to correct the varus as well as increase the slope with a single osteotomy and keep the fixator on in the femur for a couple of weeks just to ensure that the tibia doesn't recur into subluxation.
And this would be a ring fixator?
Yeah, sure. It's easy.
And the osteotomy would be in the tibia, of course?
The osteotomy would be in the tibia. With a fixator, it doesn't necessarily have to be supratuberosity because I can do a lateral translation of the distal fragment, which helps correct the Michelitz line to where we want it to come, and also a slight posterior translation of the distal fragment, which aids in the correction, which aids in getting a better slope and increasing the PPTA.
Any way that fixator could address the translation also? Could you address the translation with the fixator?
The fixator seems attractive only because of the subluxation, that I do a posterior capsulotomy open and then do the osteotomies, put on a fixator in the femur and ensure that it remains reduced, use hinges, and after a couple of weeks, start knee range of motion with the hinges on.
Okay. What about you, Sachin? Any differing thoughts? So we've got 2 opinions
so
there.
I think, so Dinsha, I'm not an expert in ring fixators at all. The concept seems very attractive. But going and breaking up this whole pathology stepwise, The first priority here is correcting the fixed posterior subluxation before I touch the bone. So correction of the fixed posterior subluxation is step one for me. I would perform a CT angio. I would look at the position of the neurovascular bundle. If it is not really plastered to the posterior capsule, I would do an arthroscopic release. I would go ahead, I would release, since it's predominantly a fixed posterior subluxation, I need to release on the back of the knee using a posterior medial and a posterolateral portal, release the capsule of the femur, and I should be able to bring back the tibia underneath the femur after I've done this. Following this, I would probably in this patient just give him a PTS brace for about 3 weeks, ensure that the tibia stays reduced, get him in a PCL brace, get back his range of motion. If his pain goes away then, which could be very well because of the fixed posterior subluxation, he may not need anything. Coming to the fact that he would require something to treat his medial compartment arthritis, I would do a planning. He has got a limb in which the MPTA is 79. If I do a medial opening wedge in this particular patient, I may find that I need to open up a huge wedge, which may be 17, 18 millimeters, which is quite a large amount of opening, which I may need to do. Of course, I've not done the planning here. You would know the numbers. But in that situation, I may consider doing a Chiba type of an osteotomy to improve his MPTA and not open such a large wedge. But this is something which I will decide once I've done my virtual planning.
Okay. Roshan, any differing thoughts?
Yeah, I will go a little different way. I will do open wedge osteotomy on tibia. For DFO, I will do a lateral.
Open anterior or open medial?
Open medial, simple. Because
Okay.
I believe that in PCL deficient knee, the moment you do open wedge osteotomy, medial open wedge, there is automatic displacement of the tibia, proximal tibia. So it reduces. In fact, that's a slope correction ideology, which was been very well presented by French group. And they do the correction osteotomy whenever they have this PCL deficient or ACL deficient knees. So probably that will suffice for his PCL as far as tibial subluxation is concerned. But as Sachin has pointed out, large tibial opening may not be a right idea. So in that situation, I would like to play with the distal femoral angle. I can do a medial closed wedge osteotomy on the DFO. So DFO, HTO, I think that should suffice his problem. And as far as capsular this thing
But
is
is
concerned,
MLDFA is all right?
yeah, but you can cheat with MLDFA a little bit, so as to get the correction on tibial side. You don't want to land up in 13, 14 degree correction, but a degree opening on the tibial side. So you can share it that with the femur as well as the tibia.
Fine.
So that will be my plan.
Atik? Any new thoughts? So
I would go a little different. I think of the three things, for me, the most important is the posterior subluxation, which you said is fixed. So I would probably work with I don't do ring fixators, but I would work with my colleague, do a posterior release and use a ring fixator in the initial phase, get him back, remove the ring fixator, get him a good range of motion, and then think of doing an osteotomy. That would be my thought process.
Okay. Santosh, are you going to give us a seventh opinion?
Yeah. So I would want to know more information on the tunnels. If the tunnels are okay for a single stage, maybe an MRI or CT would. If it's okay for a single stage, I would do a medial open capsular release, get the capsule release, get the subluxation corrected. And when the capsule heals, we need the knee to be reduced position. So reconstruction or an X-fix. Here, if the tunnels are okay, reconstruction should be done as you're opening immediately. A partially open PCL reconstruction can be done along with an osteotomy. Osteotomy again, same as.
Would you, so if you don't get correction on table, would you still go ahead with your PCL reconstruction?
No. Then there's no point. You have to get correction with releasing the posterior capsule. Otherwise, there's no point. Then you have to go with the fixator slow correction.
And so whatever PCL has been done, you just get it out. And
if you're doing an X-fix, PCL is not stage 1, it's stage 2.
Okay. So this was again a really complicated sort of situation. This guy was in a lot of pain, not able to walk. one of my friends had done the primary surgery, so I was almost obliged to do the revision. And so we took him up. This is the sort of Jackson table that I use for osteotomies. Gives me a good approach with nothing coming in between with that C-arm there. And I basically did something similar to what Roshan mentioned, except that I opened it up and did an open release posteriorly so that I could get a reduction. As soon as I did posterior capsular release, I did an arthroscopy. When the arthroscopy, the joint anteriorly was fine. So no adhesions anteriorly, nothing causing any fixed posterior subluxation anteriorly. The tunnels seemed okay, but I think it was just a lot of posterior capsular contractures there. So when I did the open approach for the osteotomy, and I went on the medial side, a medial opening wedge osteotomy with slope correction, I was able to get a fair amount of reduction thereafter, which did become a little lax. So in fact, I was thinking, should I go ahead with the PCL at the same stage, which I didn't. So I did just the osteotomy. And as Sachin mentioned, it was quite a large 14 millimeter opening that I had to do. And I also managed to increase the slope at the same time. So similar to what we just saw in the surgical demonstration there. And got his mechanical access to the lateral tibial spine. But I think that just getting him that alignment, and I gave him a call last week just to send his photographs and his x-ray, and he sent me this. This is his 4-year follow-up. And I think just getting that alignment made sure that this gentleman who was in such pain and such disability, got back. I did nothing to the PCL. I did put some bone graft in the tunnels, but nothing to the PCL, and the PCL hasn't required anything. He wasn't unstable initially, and he isn't unstable now. I suspect that he still has a grade 1 posterior sort of fixed subluxation. It's grade 1, not more than that, and therefore he doesn't have pain, and he's quite comfortable. So as you can see, sometimes you can get a complex situation, but you'll have many different ways in which you treat it based on the way that you're most comfortable with. And I think you need to choose what you're most comfortable with. And for cases like this, there's no real correct answer. There are many different correct ways in which that you could do this.
Dinshaw, just to go back.
Yeah.
What did you measure his slope after you'd done the procedure?
So it came to about 12. We managed to bring it only up to 12 because, although I'm using a Tomofix, I really didn't want to break that hinge too much. So I think if you have to go beyond a few degrees, that green stick effect can only give you an addition of maybe 3 or 4 millimeters anteriorly.
Exactly. So I think that's the point. So if you want to significantly increase that slope, because we've had a couple of similar cases where we've done what I suggested, and by significantly increasing that slope to say 15 degrees, then the femur has to roll back. Of course, we do a release, an open release at the same time as doing the procedure. But there the slope, looks relatively, well, it's 12 degrees. You've got a fantastic result. But the point is, first of all, you can skin a cat in many different ways. But if you really want to change significantly the slope, you can't do it from the side. You have to do it from the front. And as Ronald's doing, has in the past, certainly with his Abu Dhabi practice, done more slope changing osteotomies in that practice for him and for us. Changing the slope now is very straightforward. It's a great result. Great result.
Adrian, you've got a slope. This patient's got a posterior tibial slope of 8 degrees, which is normal. How much would you take it to? What's the limit that you would take it to in a PCL deficient knee where you want to get a correction?
In a situation like this, where it's so pathological, fixed subluxation, severe pain, grade 4 OA, we'd accept a high slope. You'd probably go to 15.
15.
Yeah.
But I think that's a point that needs to be taken, that if you're doing a medial opening wedge, as was suggested by Roshan, and you're trying to keep that hinge, whether you break the hinge or not, you really can't open the anterior part beyond maybe 3 or 4 millimeters. So anything beyond that, you'd have to do a standard anterior opening wedge osteotomy. This combined sort of approach wouldn't work. We go to the second case. This is a 31-year-old female. She's had a motor vehicle accident with polytrauma. She had an intra-articular fracture of her left proximal tibia. She's undergone an open reduction internal fixation and a subsequent implant removal. And she presents to me 5 months following that implant removal. So the implant removal was done because she couldn't really walk, in a lot of pain. It's a persistent limp. She needs to walk with a crutch. She has a lot of pain and instability, and she's severely functionally disabled. And she's been with rehab since the last 5 months, and she's had absolutely no relief with that. Her range is normal. She's got no stiffness, so she's not got a stiff knee. That's what a scanogram looks like. And you can see the X-rays there. Sachin, can you tell us something about these X-rays? When you see an X-ray like this, what exactly are you reading for everyone who's here in the audience?
So I think there are a couple of things, Dinshaw, in these X-rays. Do you have a X-ray? Do you have a next image for the scanogram where you've drawn the weight-bearing line? Okay, you have it. Let's go back to the previous X-ray. So very important here is that all of us should study, we always study the AP view. We forget to study the lateral view. And when we study the lateral view, that can really give us a wealth of information. What all can you see on this lateral X-ray now? One, you can see that there is posterior subluxation of the tibia. Second, you can see that there is reversal of slope. The normal AP slope of the tibia is lost. Third, you can see that there are some bony fragments in the area of the tibial tuberosity, but the patella seems to be in a decent position. So probably we're not looking with some form of abnormality of the extensor mechanism. And fourth, you can see a depression in the area, which is more based anterior rather than posterior. That will now bring us to the medial side. On the medial, to the AP view. On the AP view, what we can see is that it appears though, or it gives us an illusion that the MLDFA in this patient is going to be a bit off, because you can see that the lateral femoral condyle looks a bit hypoplastic than the medial side. Now this could be an illusion because of the collapse that we have, but this definitely needs a good preoperative assessment. You need to draw your angles before you make any blind decision on what needs to happen. And when you study the tibia, you can observe that there is definitely a double shadow on the lateral as well as on the medial side. The MPTA selectively on the medial plateau is decreased, and probably there would be areas of void within the proximal tibial metaphysis, which would need some form of addressing when you go ahead and do some form of corrective osteotomy. So which then brings us to the next part, that whenever you plan such cases, you need to always have a good preoperative CT scan to understand what is happening within the metaphyseal area in the area of the cancerous bone.
Okay. So we got some weight bearing. Do you routinely, Santosh, do you routinely do, so we know we almost always do a standing AP for the coronal. Do you routinely do sagittal views also in standing? And what sort of information can those give you?
Standing lateral view, when we measure our posterior tibial slope, we have a study which says that there's gross difference when you measure the axis, like the mechanical axis. When you draw a line from the hip to the ankle, the angles measured with hyperextended knee or FFD, that is more significant of the posterior tibial slope rather than just measuring with the shaft of tibia.
Yeah.
So standing gives totally different information based on whether the patient has slight FFD or slight hyperextension. So that information is not possible if it's not a standing.
Adrian, how do you measure your posterior tibial slope? What sort of technique do you use to measure your posterior tibial slope?
So conventionally, our measurements,
Adrian, sorry.
Yeah, so we use the two-circle method. So we come up through the middle of the circles onto the tibial plateau, and then we draw a line in line with the slope, and we base it off that axis. And all of the data is based off the short views, but in fact, of course, we need a long view down to the ankle. But it's interesting that the papers have all been based on the short view of that in terms of those circles. So then we would come up through the middle of the tibia, through the two circles, intersect, and then determine how reversed this slope is, which is causing this recurvatum. So this is complex because it's an issue medially, laterally. There's an intra-articular component. The slope is reversed, and that is a hideous problem for the patient. Probably the key two things here are the slope and that large depressed section that we saw. But of course, we have the frontal pain issues of varus as well.
Atik, when you're dealing with this, what sort of investigations, anything further that you would do? We'll come to the treatment a little later, but just in your workup, when you're dealing with a patient like this.
Sachin said, I would want a CT scan.
Okay, so we'll show you the CT scan there. So what all do you want to look for in the CT?
One, the slope is quite obviously reversed. There's some fragments anteriorly. There's I think a recovertum, which I can see. There's a defect in the proximal, in the metaphyseal area.
Yeah.
Quite a bit of a defect actually. And there's a depression also.
So we got a 3D done and the 3D with this too. Roshan, what are your thoughts? What are your initial thoughts on how you'd be planning treatment for this patient? I'm going to show you a few more images.
Yeah.
So that's the CT scan there. And that CT scan is showing us so that CT scan is showing us this area here, which is anterolateral, which seems to be a defect. I'm also going to show you the MRIs because this patient had, in fact, was referred to me for instability, primarily that she's unstable and she's painful and she probably requires a ligament reconstruction. But when you examine her clinically, she's got a stable ACL, a stable PCL, she's got a stable MCL, she's got a stable posterolateral corner too. So she's unstable primarily because of alignment. And I think that reverse posterior slope is causing a lot of that instability for her. On the MRI, you can see the MCL is okay. The lateral complex is okay. Her menisci not bad. ACL, small little ganglion there, but it's intact. And the PCL is also intact. Of course, that's the area there. This patient already had a cartilage study done, which seemed to indicate that the cartilage wasn't that bad on both the medial and the lateral side. And we can see that those were the old screw tracks there. And again, this area here, which is a little suspicious, but a patellofemoral joint is all right. So
Yeah, Dinshu.
how do you treat this?
I
Yeah.
just wanted to do a good clinical examination because I think gait and hyperextension around the knee joint will give us a lot of idea. So clinically, what was the instability around the knee? That is anterior cruciate, posterior cruciate, and lateral collateral.
So all four clinical tests show a little bit of laxity,
Okay.
but all have firm endpoints.
And gait.
Gait, she's just not able to walk. She's not able to put her leg down. She's having a crutch
So-
there, and she's almost limping with that crutch itself.
So for me, it's a malunited intra-articular fracture. You can see the lateral plateau, which was extending up to the lateral tibial plateau, the intra-articular fracture, the medial tibial condyle fracture. It is malunited and probably it has resulted in a reversal of posterior tibial slope. So addressing this issue is a little bit critical. The only way to address is by doing a good arthroscopy to see the amount of cartilage left, the quality of meniscus left.
Actually,
And
the
do a
surgeon
deflection osteotomy.
so the surgeon actually had done an arthroscopy,
Okay.
and he was thinking that it may be a ligament that he's going to
Ligament, yeah,
reconstruct. But when he did that arthroscopy, he found that the ligaments were okay.
Okay.
Surprisingly, he felt that the cartilage was okay. He was actually going to graft that area. He said, I just couldn't find any area to graft, and the meniscus looked good. So, and that's why the patient got then referred.
So here there is a role of other kind of osteotomies like deflection osteotomy, where you can correct the posterior tibial slope, especially for this female. Or you can do a TCVO, but I have no personal expertise in TCVO. But
Okay, Milind, what would you do? I know you see a huge number of these, polytrauma cases and complex trauma. What are your thoughts on this?
The AP X-ray looks as though there's an increased JLCA on the lateral side. So what I would like to do is to do stress views, stress X-rays, maybe under brief anesthesia without going ahead with any procedure to give me enough time to think and sort it out. And if there is a teeter that I see a varus JLCA and a valgus JLCA, there is definite increase, then I would consider a combined elevation of the condyle, maybe on the lateral side, but not too much. I don't want to get this patient into too much valgus because there is something going on wrong on the lateral side anterior. And of course, a correction of the recurvatum. Here in this case, definitely supratuberosity, correct, improvement.
Okay. So again, complicated case. I wasn't too sure. So I thought the best thing to do is at least get some amount of a computerized sort of evaluation done as to what would I be able to achieve. So we got an evaluation done where we could probably correct it to neutral, because I had exactly those kind of thoughts that the lateral side may not be that great. So if we had to correct it to neutral, then we'd require an opening wedge. We'd also have to correct the slope. And if I'm going to try and correct the slope, reverse it, then I'm going to require a large correction there, almost 13.4 millimeter wedge there. And to do that, then I got a PSI ready. But before I wanted that, I started with an arthroscopy. And I really want to see what to do for this. So you can see that that joint, the weight-bearing portion of the joint is good. The meniscus also perfectly all right. And this defect that's there is here anteriorly and not so much in the weight-bearing area. And I had actually planned that I'm going to do a bone grafting and possibly do autologous chondrocyte implantation subsequently if needed. But seeing that anterior part, I decided that I really didn't need to do that. Just a bone grafting would be adequate. A patellofemoral joint had mild changes on arthroscopy, though the MRI was okay. But the medial compartment had significant wear, and we can see that on the preoperative X-rays there too, and on the MRI. And so significant chondral wear on the medial side. And so I decided I'd go ahead with that. So we did a patient-specific instrumentation. So that osteotomy would include an opening wedge, and then using the stacked osteotomes, open it anteriorly to increase the slope. And we wanted to make sure that that slope, which was reversed, at least came to about 5 degrees. And then you get this special wedge that you can put in there, put in the plate, to compress the posterior part. So like you've got a laminar spreader, we've got a device where you can put 2 guide wires and compress the posterior part so that you can the anterior part of the osteotomy can be open, and then go ahead and fix it and put in bone graft. And because that medial side was off, I wanted to really bring her almost up to Fujisawa point. And surprisingly, with that slope correction and a single stage sort of procedure, she's at least able to walk and is quite comfortable, and she's quite happy with this procedure. No ligament reconstruction was done for her. We get to the third one, and this is something that we very commonly see in India. So this is a failed ACL, and he's failed twice. So this is a 39-year-old male. He's a recreational football player. He's undergone 2 prior failed left knee ACL reconstructions, one in 2009 and one in 2017. And the second one had a partial medial meniscectomy and a lateral extraarticular tenodesis. Now he comes with persistent instability. He's got medial sided knee pain since 9 months. He stopped playing, but he's still very painful. And his Lachman is grade 3 with a varus malalignment. Sachin, what are your thoughts on this? 2 prior failed ACLs, malalignment with varus. On the X-ray, we can see that there's medial compartment OA already setting in there. And when you see his MPTA is 83, his MLDFA is 90, joint closing angle 3 degrees, his posterior tibial slope 23 degrees.
So we're dealing with 2 issues here. One is obviously arthritis, a medial compartment arthritis with so we're dealing with 2 different issues here. One is instability and the other is pain. The instability and his failure of his ACL is because of an extremely high slope, which is as high as 23, which needs to be definitely corrected and brought back to at least about 5 to 7 degrees. He's got arthritis basically because of 2 failed ACLs, because of a partial medial meniscectomy, and now he's drifted into somewhat of a double varus deformity with metaphyseal varus as well as amount of laxity of his lateral structures, which is going to happen once you've had 2 failed ACLs. His JLCA is not very high, which is a good thing. Now here, the options that we have is that we should do a complete preoperative assessment. Your 2 mainstays of treatment include bony correction, correction of his mechanical alignment, correction of his posterior tibial slope. And to tackle the instability part, we need to consider doing some form of ligament surgery on his ACL. A CT scan is essential, a CT to look at the amount of tunnel dilatation and to also decide if one would be able to do a single stage procedure or one would require a two-stage procedure. If we feel that there is a large amount of tunnel dilatation, that in that instance, I would do a two-stage procedure where I would tackle the bony correction first and then come back and do a second stage ACL. So what we really need to do is to do a good preoperative planning, look at his angles, look at the amount of opening, and we need to correct his slope by purposefully under low energy breaking the hinge and do an intraoperative correction of the slope, do good monitoring of the slope by doing frequent lateral x-rays when we're doing surgery. The other option is to, of course, do a PSI, and then you can manipulate the hinge point to try and do an oblique plane osteotomy to get your correction back.
Atik, what about you?
CT scan definitely to see the status of the joint and the tunnels in space.
Yeah.
That
So
I
he's
would
got, two femoral tunnels. I think the first procedure was probably a transtibial. If you see that, it probably was a transtibial. And then the second procedure is probably a transportal, at least on the femoral side from the two sort of tunnels that are seen. And that's his screw of his lateral extraarticular tenodesis there. And in the MRI, we can see that that's the screw there. You can also appreciate his medial joint space.
Does he have any meniscus left or?
Almost no meniscus left.
Okay, so he's got a complete, almost like a subtotal meniscectomy.
Probably
now.
a subtotal meniscectomy was
So
performed.
that's
for
one
him.
more cause of his pain. He doesn't have any meniscus there.
Yeah.
So after the CT scan, I would decide whether to, if there's a lot of tunnel widening, I would probably do grafting of the tunnels and do an slope correction osteotomy at the same time. And then later on decide whether he needs any ligament reconstruction or not.
Okay. Adrian, any tips on this? Do you see a lot of these, slope problems causing failure of ACL and it's not picked up during the revision?
I don't think this is that uncommon actually. So I think he's not massively varus with an MPT of 88 and he looks clinically to be a bit varus. I think I totally agree with Sachi in terms of the assessment. I think a CT scan's crucial to work out whether you can do a third revision ACL as a single stage and allograft. Assuming you could, then I would do an anterior closing wedge. I would do a third revision ACL, and I would do as a revision for the lateral side, I would do an anterolateral ligament reconstruction as opposed to a further LET. I think this guy, if he's, he's young, he's 39, this chap probably is someone that you need to consider with ongoing symptoms of pain and meniscal transplant, but that would be a staged. So I think the key here is correct the slope. The next thing is to correct the varus. The third thing is to correct the instability. And finally, then we would look at the meniscus.
Okay. Santoshi asked you, I love football. With all this that you're going to do, can I get back to football?
I wouldn't promise him to get back to football. I would keep him warned. I would ask how much does he want to play football? How much committed is he?
Yeah, he's really young. He's 39.
He can go, but we cannot assure how long he's going to play and how much he'll be able to play. We cannot come.
Roshan, what about you? When you're counseling these patients for sports, would you allow it? He's had 2 prior failed ACLs. He's already got medial compartment OA. The procedure you're going to do is almost going to be like a salvage procedure. Are you going to allow sports, or how do you counsel them?
So I think return to sports is a very, very subjective phenomenon. And especially when you're doing something extraordinary surgery. See, deflection osteotomies are not a regular osteotomies. They are very, very unstable osteotomy. Now we have a fixation device, but otherwise we use only the staples. In those situations, the healing is very, very, healing is fast because of the metaphyseal bone, but it's delayed. So I feel he may not be able to go back to his pre-injury status. However, he will get a stable knee where he can do all his activities of daily life. Playing a contact game after osteotomies is again in our part of the world is very, very difficult. He can play cricket, which is a lazy game, not football.
Cricket's not a lazy game. Yeah. But okay, so he certainly had enough of surgeries and he didn't want to do it, too many stages, etc. So I counseled him that I don't think football is really going to be feasible for you. I think the first thing is get your slope corrected, get your alignment, and we'll bone graft your tunnels at the same time. And then we'll see if we require anything thereafter, because if for graft, we're going to have to go to an allograft, and he doesn't have a meniscus. So then we may have to consider a meniscus transplant and an allograft at the same stage. And so we've done the osteotomy. We've decreased the slope. And he's about 9 months now down the line. He's, of course, happy with working. He's not playing. And surprisingly, he's quite stable. So stable in his day-to-day activities. So Adrian, do you think that that slope correction itself gives you a fair amount of stability for your day-to-day life? This guy was unstable prior to the osteotomy. We've done no ligament reconstruction, and he feels much more stable now just because we've taken care of his slope.
I think the instability comes from two things. One is that AP laxity, and I forget what the clinical examination was like in terms of Lachman and pivot and so on.
A grade 3 Lachman, yeah.
So, but a lot of the instability is also coming from the pain. So once the medial side is offloaded, they don't have that reflex inhibition and instability from the pain. So a lot of them will feel a lot more stable as a result of that. And you've done very well to correct such a high slope to where you are with the from a medial approach. So yeah.
How many would do a lateral closing wedge osteotomy for this? It's much easier to, decrease the slope with the lateral closing wedge, and that would be a stable osteotomy. Would any of you consider a lateral closing wedge for this?
If I cannot do a deflection, my first choice will be anterior close wedge. If I cannot do, because there was a patella alta, you can see a good amount of patella, so I can do a good amount of anterior close wedge osteotomy. But in case I'm not expert enough to do anterior close wedge, I would have done a lateral close wedge osteotomy for this patient, because that will naturally get stability for his ACL.
Okay.
I have a bit of an interesting observation about his preoperative lateral X-ray.
Yeah.
And I would really love to see a full-length lateral of the opposite normal side. He has what I think is an procurvatum. If you go into deformity analysis, he seems to have an procurvatum in the lower part of the tibia as well. And there's something that I would look at as a deformity correction surgeon. I would not hesitate to do it at 2 levels to get a very effective correction of the PPT at the posterior proximal tibial angle.
Tell us a little more about that, Milind.
See, if you look at his preoperative lateral X-ray,
yes,
there is a certain anti-curvation in the middle third.
Mid diaphysis, yes.
There is a little bit of a compensatory recurvatum lower down in the canal, you can see.
Okay.
So I would love to measure it at 2 levels. We have these 2-level deformities. So we draw the anatomical axis of the circles at 2 levels. And we will find 2 coras, that is centers of rotation of angulation. One would be higher up, one would be somewhere lower down. And I would be a little reluctant to try and correct 15 or 18 degrees at the upper level, especially if it's above the tuberosity. And with an external fixator and angulation translation, you can correct large amounts of angular deformities.
So your 2 levels of osteotomy would be where? Exactly at the apex of these in the diaphysis?
Yes. So the first is where you did it, and the second may be added on at a lower level. Maybe.
Okay, so that's so interesting. Thank you.
Are you concerned about doing a diaphyseal osteotomy in compact bone in a 40-year-old?
Never.
Never.
Never worry. Because we can compress dynamically with an external fixation. Without that, yes, with a plate, I would be worried. I agree. I agree with you. I agree.
And the external fixator would necessarily be a ring fixator?
It can be anything. We are not married to any kind of device.
Okay, we'll get to the next case. So this is a 21-year-old male. He's had insidious onset right knee lateral pain since the last 9 months. And then recently, so he's been living with that. And then he comes to me basically because he started recent onset catching and almost a sensation of locking. And this is persistent despite him resting and taking physiotherapy. On the MRI, we can see that he's got a complex tear of the lateral meniscus there. So there's a radial component, there's a horizontal cleavage component there, and he's got a perimeniscal cyst. We'll see a few more MRI images there. That's the perimeniscal cyst. So that's the radial component of the lateral tear. You can see the horizontal cleavage component there. That's the cyst there in the front. So that's his meniscus. Again, we can see that's the cyst there. So it's a complex tear of the lateral meniscus. And he's got an alignment which is like this. So this is his right knee. And he's got a lateral meniscus complex tear with a cyst. And you can see his alignment view out there. Santosh, how would you treat this patient? Just meniscus or realignment or only realignment? What are your thoughts on this?
First, meniscus definitely. Bony realignment, I would discuss with the patient whether I would suggest LDFA and MPTA. LDFA.
So I'll just come to that a little later, but you can see that this is significantly.
The awareness is there. I would definitely discuss with the patient and give him out options whether you want it now or you can do it later. Meniscus repair as the first stage for now.
Okay. Adrian, what are your thoughts?
So I think that's very difficult to repair that meniscus. So this guy needs an osteotomy, and he needs a meniscal debridement potentially.
Why osteotomy?
So this meniscus is going to fail if you do anything to it without changing the alignment. But it's a very, very difficult sell. And all of your colleagues that he goes to see, if he has other opinions, are not going to say that, because it's a difficult sell to a 21-year-old who's 9 months down the line. So this is someone you take on a journey. So you start off with an injection. And you say, how do you feel now that we've filled your knee with local anesthetic?
Well, actually, he's already had an injection, the cyst, and he had no significant relief with that. And so he's already had one corticosteroid injection in the cyst, which didn't give him too much relief.
So I think the cyst and an intra-articular, see how you go. He comes back to you, says, doctor, this is still killing me, help me. The next thing to do is an arthroscopic debridement and decompress the cyst. He comes back to you and he says, it's still sore. And you start to warn him right the way from the beginning, you know, you've got this bad alignment, you've got this bad alignment. And the guy is not going to settle. So at that later stage, you then start to talk to him sensibly about an osteotomy. And that is what we would do, assuming that he had an appropriate axis issue.
Atik, what about you?
I would just tackle the meniscus first.
Okay.
Because it's he's only 21, so I would rather wait. I don't know.
Sachin?
He's come to you for pain. The pain is coming from the meniscus. The meniscus has a cyst. The meniscus looks absolutely crappy. There's a radial tear, there's a horizontal cleavage tear. And the reason whatever you do on that meniscus is not going to give the best of the result is his alignment. So I think this requires a discussion with the patient and his family. They're obviously going to run away from you once you give them the whole lot. But I think if you talk to them sensibly and tell them that your pain is coming from a cyst, which is as a result of a horizontal cleavage tear and a radial tear, which has happened because your meniscus is crappy, which requires a repair. And that repair is unlikely to succeed because what was physiological for you is now pathological. And tell them that if you want the best chance of success, then you need to have the whole lot done. And you could very well easily do it in one single surgery. If he's logical and sensible, he'll agree. And I think I would be happy to do everything in one go. I wouldn't want him to I wouldn't want to get him back for 3-4 surgeries.
Okay. Okay, so what did I do? I exactly that. So I thought, you know, this is insidious onset pain. He had no trauma, nothing. Just slowly, gradually became worse, worse, worse. So the alignment, of course, had a major issue. And so we got a complete evaluation also done. And we found that these were what his angles were. So his MLDFA is 83. His MPTA is okay. But more importantly, his version is abnormal. So, you know, he has the normal version would be 12 to 15 degrees of femoral anteversion. He's in fact at -4 to 5 degrees of version. And, and so we thought that we need to correct, of course, the valgus. And so that's going to be medial closing wedge osteotomy, DFO, and bring it to about 88. But what about the rotation? I mean, should we really correct the rotation? Do you think the rotation has any sort of role to play? His opposite side, surprisingly, was normal as far as the femoral anteversion is concerned. Roshan, what would you do? Would you do an osteotomy first or just let it be?
Dincho, I think past 20, 25 years when we started attending meeting, I learned it very simple, keep it very simple. KISS. So I think this, I totally agree with Sachin. This patient has come to me with only complaint of pain. I'll keep everything in mind. You know, he had a bad antivirus.
Osteotomy, yes, no.
No osteotomy. Only
Sachin is saying
arthroscopy.
osteotomy.
But Sachin, you said osteotomy?
Of
Yes,
course.
I said I will counsel him for everything.
Counseling.
And he
First-
needs to understand.
First arthroscopy.
If he agrees, I want to do everything.
Okay.
If he does not agree, I will make an informed consent that his arthroscopy is likely to fail because we've not corrected his mechanical problems. Especially so now that we know with a good deformity analysis that there is a definite difference between his right side and his left side.
Dincho, but what I like to see in this case is gait. Gait is a very, very important examination of gait, the way he walks. If he has got natural valgus similar to his other side with little bit of anteversion, I will skillfully neglect it, do an arthroscopy, a simple surgery with a predictable result. At later date, I will inform him that you might require correction of anteversion as well as the DFO for medial side.
Yeah, Milind? Do you think that there's a risk that you do the meniscus, but you don't take care of the alignment? And now the next time he comes to you, so the first time he's lost a little bit of meniscus, and the next time he comes to you, he's lost even more meniscus, and you're pushing him into a transplant subsequently.
It's a effect rather than the cause. And in every valgus, I would like to add, I mean, you guys are all experts in the meniscus part, which I'm not. Every valgus, we look carefully for hip rotations, every case. And here the valgus is exacerbated by the retroversion, which is external rotation, which shifts the axis more laterally. Though on the X-rays, it seems as though the MLDFA is closer to 90 rather than into valgus, and the tibia is definitely into valgus. So here is a situation in which you may need to perform a femoral derotation and a correction of the valgus in the tibia, along with the other treatments as Sachin and all of you have suggested for the meniscus.
Where would you do your derotation, proximally or distally?
I'm told you can do this with a distal osteotomy as well with a biplanar. You open it up a little more medially. To do a biplanar, you open it a little more medially, you add a little bit of a graft, and you know, or you can do an opening wedge and open it up and put in a graft. Okay, derotate, take the distal fragment into internal rotation, a closing wedge. Sorry, resect a little more on the medial side in the biplanar osteotomy, along with the correction of the valgus a little bit. And this way you correct the rotation, you bring it into internal rotation. That corrects his retroversion. And there is some valgus in the tibia as well, which I would correct with a closing wedge osteotomy in the upper metaphysis.
Okay. Roshan, you know, we noticed nothing wrong with his gait. Often these guys compensate so well. So he didn't have any in-toeing or, you know, external sort of foot, you know, going ex-toeing sort of gait. But when we examined him exactly this, we found a difference in his hip rotations, and that made us do the CT scan and get his hip evaluated. Adrian, when you find a situation like this, where you said you're going to do a distal femoral osteotomy, you're going to correct him, but you've now found that he also has a rotational issue, how would you address these patients?
Yeah, I mean, for us, to be honest, our evaluation wouldn't have picked up the rotation as we picked up clinically. So we don't get a rotational CT as a routine for someone with a chronic meniscal tear, parameniscal cyst and valgus. We just don't do it. And you did very well to pick up the retroversion. Now that we know that he's got retroversion, also, I think for me, this is the big take-home message from the meeting. So every time I see someone whose axis is lateral, I'm always going to get a rotation now if they have a lateral issue. That's a massive take-home message for me from this course. So thank you. Now that I know where we are, then of course we would address we would want to know what the tibial rotation was, because of course whatever you do to the femur is going to affect the tibia. So of course if this chap if his tibia is out, if you then internally rotate his femur, you need to look at the foot, because actually if you do a 15, you want to get this guy to, let's say, between 15 and 20 degrees of femoral version, which means you need to do a 15 to 20 degree correction here. If you're going to do that, his foot is then going to internally rotate by 15 to 20 degrees. So we then need to look at the tibia and make sure that we don't need to do a further correction there to bring his tibia back. But we would always do the correction distally. We would plan here to do a correction of both the valgus and the rotation, but do it acutely with a plate.
Okay, so that was exactly my plan. I think I discussed it with the patient. Intelligent patient understood that if we didn't correct the alignment, he's probably going to land up with problems with the meniscus. My initial plan actually was to try and repair the meniscus, but he had a partial discoid. So you see this is slightly larger, it's a partial discoid, and then it didn't just make sense to repair that. So I had to trim it off, but he did have a fair amount of his remnant lateral meniscus there. So I'm just going to try and fast forward that. So trimmed off exactly this. He had a small horizontal cleavage here. So I took one single suture here just to close the horizontal cleavage tear, and then went ahead with the so trimmed off that portion and then went ahead with the osteotomy. So normally I do a biplanar osteotomy, but I find that if I do a biplanar, I really can't do the correction there too well. So here I did a uniplanar and then did the correction. We basically wanted to bring him to about 10 degrees of anteversion. So that meant almost 15. But we were really lucky that his tibia didn't have a deformity. So we didn't have to touch anything on his tibia. And subsequently, that's his alignment. His alignment now, we've brought him into a neutral sort of plane. And he's quite happy. His pain on the lateral side has gone. And I'm not so sure that if I didn't do that osteotomy, he would have, I suspect that he would probably have come back with pain, and that would have meant a failed meniscus surgery.
Eventually, is going to require HTO on medial side.
HTO on the
Medial side. So now he's in varus.
No, he's not in varus. He's in normal alignment there. So in fact, we corrected the MLDA fate only 88. We didn't go up to 90.
But probably the most important thing for that case is to actually get his frontal axis to neutral, which you've done beautifully. The rotation, it's important, but it's not usually a massive driver of lateral meniscal pathology. So I think the key here was the closing wedge medial, which has got the axis beautiful. And then you did exactly the right thing, remnant preserving meniscal surgery. You want to do as little as you possibly can to the meniscus. And I think they do very well.
How much derotation did you manage with this?
So when you do, exactly what Adrian was mentioning, because his tibia is normal. If you rotate too much, you're going to start putting his foot in a different angle. So he was at 4 degrees retro. We wanted to bring him up to 10. So we did a 15 degrees of rotation.
So eventually he's going to walk with intoing.
No, so I think up to 15 to 20 degrees, they compensate really well. So why do these guys who have a genu valgum, when they're actually walking, you see that their gait is almost as good as normal. And it's only when you do a scanogram or you get them into the anatomical alignment, you observe these small amounts of genu valgum. I think that they compensate really well at the hip. Okay, so we'll get to the fifth case. We've got 3 or 4 minutes. So this is a 32-year-old male. He's a recreational tennis player. I did his left knee ACL reconstruction in 2012, and we noted at that time that he had multiple osteochondromatosis, and his right knee had a significant valgus. And I said, look, that right knee looks terrible. And he said, no, I've got no problem at all. I've been playing tennis, and I'm fine with it. And he came back to me 2 years later, with right knee lateral pain. So it's mild. He's getting fatigue pain. He's got no tender exostosis. Clinically, his knee is normal. His patellofemoral joint is normal. His MRI, again, the knee is normal. And we've done a CT scan, no torsional abnormality there. So that's his CT. And that's his scanogram. And that's his, those are his sort of angles there. Milind, how would you deal with this?
Firstly, with many due apologies, it's not a scanogram.
Okay, I know. So weight bearing X-ray, I'll say that.
No, sir, it's a full length X-ray. A scanogram is a 3 exposure X-ray taken without the patient.
I know.
moving. Sorry about that.
Yeah.
And that's to measure the.
And tell us the name of what the actual.
It's the teleoröntgenogram.
Perfect.
And
Thank you.
the scanogram is an orthoröntgenogram taken with 3 exposures of the patient lying on a Bucky film when you want to estimate leg length difference in the presence of contractures in the hip or the knee to get a very accurate estimate of the LLD, which is coming from either the femur or the tibia. But that's, I'm sorry, it's unnecessary. I'm splitting hair. Let's get on with the case.
Now, I learned that from you at a prior meeting where many years back you had mentioned the same thing. But I still call these scanograms primarily because
as does everybody else.
Yeah.
I'm sorry. But this is probably a little longer leg, and that's probably contributing. I won't be able to measure it because I'm not.
The
having a
limb
parallel
length
view.
discrepancy, the true limb length discrepancy is 31 millimeters.
And this side is longer.
Yeah.
So this is long leg arthritis combined with valgus. So this in MHE multiple exostosis, they typically have these things. They have LLD. And when you want to, if they have bilateral deformities, you have to factor in the LLD. So here you could do it with a combined with a trapezoidal shortening osteotomy and correct his valgus. And I would love to know how much is the MLD phase 80. So he'd need on both the places. So you can break up the shortening both in the femur and the tibia, do some in the femur, do some in the tibia. And also you'll have to resect the fibula, of course, and you resect more medially and resect a little less lateral. That's how you correct the valgus as well as the extra length.
What about you, Adrian?
So, yeah, I think the leg length is an important element here. Severe valgus, double level deformity. So for us, closing femur, closing tibia, that would give us no increased length. Of course, the problem that you do have is his leg currently is long and it's in valgus. And even if you do two closing wedge procedures, when you get his axis straight, he's going to have an effective lengthening from that. So he's still probably going to end up a bit long. But that's what I think I would do there.
Any other opinions on this? Would anyone, what about the nerve? In what sort of situations would you do a peroneal nerve release when you're going to be doing a correction? Now, Milind, what are the indications? I mean, what sort of angles, what are your suggestions on when you're doing a severe valgus correction and you're doing it at one stage?
Always
Always.
a prophylactic lateral popliteal nerve release, not just at the neck of the fibula, but going down into the, the intramuscular septum between the lateral and the anterior compartments as well. Always, even if it's only a tibial, always.
Roshan,
I would have approached this patient a little bit because you see the proximal tibiofibular joint being problematic here.
Yeah.
So I would have excised the proximal tibiofibular joint, released the nerve, and same time I would have done an open lateral tibial osteotomy so that you can get the correction of tibial side. Similarly, I would have added the DFO on medial side. So medial closed wedge osteotomy, take the graft and put it on the lateral tibial side. So that will correct both, release the nerve, excise the distal proximal tibiofibular joint so that you can get a rotatory element. Because if you make it tight joint, because if you see he doesn't have any joint on the proximal tibiofibular area.
So in fact, I did a closing wedge on the medial side so that I could shorten him a bit, and closing here on the femur 2 and release the nerve, because that was, I think, my main sort of worry. And that's his post-op scanogram. And he's back to tennis actually. So he's back to tennis, and he's been, this is many, many years back, and he's quite a happy patient. So you need to do it at 2 levels. Okay, so we'll do just one last case. Okay, just one last case, very quickly. So this is a 50-year-old male, and he's now come with left-sided medial knee pain. And we can see that he's got a very classical spontaneous osteonecrosis of the knee there, almost an OCD sort of picture. It's only on the left side. That's his alignment. So his alignment, he's in mild varus, just very, very minimal. It's going, his MPTA is 85, and that's his Mikulicz line there. He's got a mild amount of this medial lesions, and that's the OCD. A lot of bone edema there. How would you treat this patient? So 47 years old with a medial femoral condyle OCD and with a very mild varus. Sachin. He has a hip replacement on the opposite side. Yeah.
So we know very well that if you look at, I think, the paper from Aaron Critch, the number one reason for failure of cartilage procedures is malalignment. And in their series, I think they had 55% of all their failures which were attributed to improper correction of malalignment. So here, bone takes precedence. We need to correct his alignment. And he's 47, you said?
47.
Probably looking at the size of the lesion, I would measure it on a CT scan, and I would probably look out for doing either a fresh frozen osteochondral allograft. We can use one of those hydroxyapatite coated mini plugs because he's 47. Of course, I don't have any experience of the same, and we don't have any significant long-term literature on that. These would be my 2 choices in treating this patient.
So what's your cutoff? Adrian, what's your cutoff for what would you consider malalignment? So when you see that he's got a lesion on the medial side, and is this significant malalignment for you? So what's significant malalignment?
Yes, a mechanical axis deviation more than 2 standard deviations. So for me, this is a malaligned knee, and so I totally agree with Sachin. I would push him to the lateral spine. In terms of the cartilage lesion, Chris Wilson's got a really nice series of 5 of these osteochondritis patients that varied in age, where he had spontaneous healing. We've seen that as well. Obviously, we tend to do this on younger patients, and it's quite unusual to be treating osteochondritis in people in their 40s. But we would go for bony correction first, micro drilling just to give it a chance, and then second stage, if there was persisting pain, would be an osteochondral, because it's too big for an oats, would be an osteochondral allograft fresh.
Okay, I think now he comes to you and he says he's an investment banker. He needs to do at least 3 or 4 visits to New York up and down every month. He says, I've got no time for any of this. I need something that's quick. He's sedentary. He plays no sport, nothing. All he wants to do is make money. So he's flying up and down. He says, I can't really do all this rehab and everything that you're saying. So if you're going to do a cartilage repair procedure, you're going to keep me non-weight bearing.
Probably speak to him about a UK.
A uni knee, yeah? Would that allow him to get back to normalcy faster?
Yes. I would speak to him about it.
Okay, Santosh, any other thoughts on this? So I saw the lesion there, arthroscopically. That cap was completely off, completely loose. So I had to take that cap off. And that's the lesion there.
Probably, if he's having time, probably an ACI with osteotomy.
Yeah, so I explained all that to him, and he said, out of the question, you know, my lifestyle just doesn't allow that. So what did I do? So I did a focal resurfacing, which would just then allow him immediate, you know, normalcy. He's 47, sedentary, and this allows him, you know, to get back to normalcy immediately. You take care of the cartilage, and you've left it alone. So Sachin, your thoughts on this?
Yeah, I think I'd probably do a fixed bearing UK for him. It'll give him at least 25 years rather than 5 to 10 years.
So
Do you think this would give him only 5 to 10 years?
Possibly. That's all the data that we have right now.
Resurfacing doesn't have a very long lifespan, and then also it's known to cause cartilage defects on other places
I
around.
think this
Yeah.
patient is already undergone a THR on one side, on your scanogram.
On the
I
right
could
side,
see the
yeah.
right side. So
Opposite.
probably a UKR would have been far better. He doesn't have to play a football or cricket now. He's a very, very sedentary lifestyle. So probably a UKR will be a fine.
But we just heard the indications for UKR, and here you've got absolutely normal cartilage on the tibia, and you've got absolutely normal cartilage all around in the femur. It's just that small focal area. Why would you want to do a
So
UKR?
let's understand. All of us are 50 around. How many of you agree for
And of course,
resurfacing?
this is a patient specific. So this is not your earlier type of resurfacing. These
So
are the
this is
PSI. This is episurf. This is episurf.
So how many of us will agree for Santosh? If you are patient, you will do this?
No, there was subchondral edema.
No, yes or no,
and,
Santosh? Yes or no?
No, the reason
No,
I need to
Adrian? No. Sachin, you are patient?
Dinshaw is the moderator. He gets to ask the questions. We are not the moderators.
Yeah.
So
So
I think Dinshaw,
Just
this
a
is
fact.
So I feel UKR is far, far better
No,
in that.
I think
So-
he's already had a total hip on one side.
Yeah.
Probably
Same side.
susceptibility of a UKR.
So
on the other side.
osteonecrosis is a valid indication to do a UKR. So indication wise, Dinshaw, you are correct. A UKR is also correct. It's a very good, you are dealing with a very well-educated person who has access to all information. So I think a good counseling, and these are probably gray zones where everyone is right, everyone is correct. And a good informed decision between both parties is what is really required. That's my gut feeling. There's
Okay.
nothing wrong in this. This is going to do really well. He's going to be able to go back to leisure sport. He's going to recover really fast. But at the same time, I think, UKR is probably also a good answer for his problem.
Why not bio uni for this patient? He's
Sorry?
an affording patient, bio uni, osteochondral allograft with Arthrex design zigs.
the rehab associated with that, you're going to have to keep him non-weight bearing. You're going to have to keep him non-weight bearing. He has no time for that. And if you have a malalignment, exactly what was mentioned, you've got a mild malalignment too. Any cartilage procedure that you do is going to fail. So if you're going to do it, then you're going to have to do an osteotomy with a cartilage procedure. It's going to have a long rehab. If he wants a one-shot quick fix, then hopefully this is the option. Milind, your last word.
Tomihisa Koshino had a large series on SPONGs, on osteonecrosis, treated by osteotomy. If you look at his preoperative scanogram, his THR side, the opposite side, is shorter. This is a longer leg. So with the modern osteotomies being so friendly for rehab, I would not hesitate to offer him a closing wedge osteotomy with a very nice plate, which allows him full weight bearing very soon, just a couple of days of crutches when he flies.
Thank you. Thank you. So as we saw, in this panel, you got a lot of opinions. So every case that's a little complex or very complex, you've got many different options, and you really need to choose based on your patient, your needs, and consider all the factors there. But I think the message here is don't forget alignment. When you're doing your ligaments, your meniscus, you're doing your cartilage work, don't forget alignment. Alignment is the key to ensuring that your patient gets a good result. Thank you.
Thank you for that good take-home message, for a wonderful panel discussion. Now, may I now request Raghu Reddy. Panel members are requested to please be seated. Panel members requested, please be seated.
Sachin, another 15 minutes.
Is it one more panel?
Yes.
You're going to test our patience. Huh?
Yeah.
One more panel.
Yeah, it is interesting cases. Too interesting.
Good photos, huh?
So 60 years male, a farmer. Already I did a right knee surgery before going to left knee. He says he wants to work for another 10, 15 years. This is already morning we heard. So we can do this case by anatomic osteotomy, but I did by kinematic osteotomy, by the Christian's formula n-2/2. But I didn't do that. I did a TCO with open wedge. And I've told to come after 3 months for other leg, but he disappeared and he has come after 2 years. So this, see the other leg, this is a thing. So one leg is done, he's happy. After now he has complaining for left knee deformity. Now how to do this joint preservation? He's a farmer, he does farming himself. Starting from Santosh.
Sorry, your question.
How do you manage that left knee? One knee is already done 2 years back. And left leg has increased further. Now, how do you manage the other leg, which is non-operated leg? What do you want to do? Whether you want to go for preservation or replacement, what you want?
So if he's happy with the opposite side, I would suggest an osteotomy on this side also. MPTA is 83. Initially, I saw a TCVO. This is HTO, right? Okay.
Right side, I did TCO.
That was TCO. Okay.
See, right side, I did a TCO and I told him to get the other leg, left knee, 3 months later, but he disappeared and he has come 2 years later. One leg is happy now. Now this is, we are thinking on left knee. Right knee is done. Now what do you want to do for left knee? Preservation, replacement?
62. Okay.
So farmer, he's already doing farming every day.
So if he's happy with the opposite side, I would suggest an osteotomy. But
What do you want to do? Coming to, we don't have time. What do you want to do? Tell me.
I would do a HTO because I'm not experienced in TCVO.
Yeah. Adrian.
He seems to have done a very nice job on the other side, so looks like he needs a repeat.
I'll do a fixed bearing UKR with a DFO.
Roshan.
Come to 2 steps,
Yeah,
You come to an elite surgeon. So I'm going to consider the same way it has been done on the other side. If patient is very, very happy on one side, I'm very sure he'll be happy on the other side as well.
With LDFA of 93, you will do the same thing.
Yeah, if he has managed with this and he is okay with it, look at his LDF on the operated side.
Atik.
He's got a very oblique joint line.
What's his activity level?
He is doing farming. He's ploughing the fields himself.
I'll go for the same one then because I'll go for this. He's a farmer, right?
Yes.
Okay, go for this.
Milan Sodhi sir.
Raghuver, if he has on his full length X-ray, the left side is shorter
Yeah.
and the deformity is very large. It's almost like a pagoda tibia. So the TCVO is brilliant, but by itself, it cannot correct the mechanical axis. So I would do an intra-articular TCVO combined with a distal extra-articular dome osteotomy to bring his mechanical axis out completely. Can be done with a plate or can be done with a fixator.
Okay.
You had done TCVO plus HTO on other side, right?
Yeah. What I did is
TCVO and
with
HTO.
open wedge
Open wedge osteotomy.
inside
right? Okay.
one level.
So same procedure you replicate on the other side.
Yeah. So what I did is I did distal femoral osteotomy and TCVO. 7 mm close wedge, TCO 10 mm. And it's back to work. So these Japanese guys,
Now
They are
he will
com-
ask the DF on the other side
for a
also.
long-term survival of the osteotomy, if less than 60 years, they said try to do even 2 level. So anything less than 6 or more than 6, they do like this. Morning we have done open wedge, double level, which Christian is going to do. If more than 6, either we have to do combination of DFO, TCO or open wedge. But in Indian patients, if patient is more than elderly and more than 60 years, I don't do DFO. I just manage with open wedge, TCO and only. And most of Indian patients have LDFA is normal, mostly. So take home message in this is, when you are doing a open wedge in large, what Santosh was saying, if you want to do medial open wedge in large JLCA, pagoda, they can go with abnormal overcorrection. So try to do the formula, and there is a role of TCU or Indian patients. So another 5 minutes. This patient had a polytrauma. One surgeon has done lateral closed wedge HTO in 2017. 2 years later, he did PCL reconstruction. Presented to me with severe anterior knee pain, difficult to climb steps, not able to walk 1 kilometer, hyperextension 25 degrees, and grade 2 PLC. Standing scanograms and late 16 degrees anterior reverse tibial slope, 16 degrees. Percentage mechanical access, 28%. So already the UCL is done here. You can see the UCL tunnel. So what to do in this case? Young man, hyperextension. How do you manage? Santosh?
Remove all the implants.
Yeah, implant or after implant remove this is thing.
Implant removal already done. So slope correction osteotomy, where you need to increase the slope.
What you are doing to what Disha has done? PSI or?
I would do a posterior closing wedge osteotomy.
Posterior closing wedge from
Yeah.
posterior side.
Yeah, I've got a couple of cases with the fibular osteotomy.
Adrian. I think Adrian knows this.
So this is a chronic PCL, recurvatum, reverse slope. So I think this is a flexion osteotomy with a just bone grafting of take out the screws, bone graft, and do a flexion osteotomy. I think that's what I would do.
Sound is not audible. Sound. Sachin.
So this is obviously the problem here is that there's reversal of the slope in the coronal plane. It doesn't look too bad. Tibial tubercle osteotomy, lift it off, and then do anterior opening wedge with differential opening, more on the medial, less on the lateral. Try and correct maybe 2 or 3 degrees in the coronal plane. Bring this slope back to about 9 degrees or so. And iliac crest tricortical bone graft, put the tibial tubercle back on, fix it with 3 screws, 2 staples on both sides.
Regarding PCL? PCL? PCL.
PCL, nothing to be done to the PCL. He's had like 4 surgeries now. Let me get his slope back where it was. He'll probably not require any more surgeries. He's already fed up of surgeons by now.
Milan, how do you want?
Correct the slope. Correct the slope. This leg is already shorter because of the reverse slope. And you need an opening wedge bone grafting. Or you can do an infratuberosity. Both choices are there.
Infratuberosity, Eliezer Rao.
No. Classic above the tuberosity because he's got a bone loss above the tuberosity. Opening wedge, bone grafting, plate. Will do well. Open wedge.
You will take up the tuberosity.
Yes, to gain access, to be able to nicely
Okay.
correct the slope on both sides of the patellar ligament.
Atik, any different way?
He has arthritic changes on both sides. That's a bit of a concern for me. So, but he has instability, so probably just a anterior opening edge slope correction osteotomy as of now.
Roshan.
I'll do same what Atika said, the anterior opening wedge.
Sachin, you said this patient you are doing the anterior open wedge. And how do you rehabilitate? How you fix? You said staples. You said you'll fix with the staples.
Yeah, so once you do it.
But what is the rehab protocol in this patient? If you have done this procedure, what you have said?
So because you're going to take off the tibial tubercle, I will allow them 0 to 90 degrees of knee bending, but I will not allow them weight bearing for 3 to 4 weeks. This tibial tuberosity fragment that you take off will heal pretty well in about 4 weeks time. Check X-ray at 4 weeks, and once they've healed, they're allowed graduated weight bearing.
Adrian, any comments? Rehab?
I fully agree. I get them 0 to 90 on the bed, then I lock them in the extension, touch weight bearing for 4 weeks, check x-ray, everything looks good, full weight bearing after that. And as Sachin said, in this case, just we're all cased out, but definitely we do an asymmetric opening to correct as much of that varus as I could. And you could probably bring it to about, I don't know, maybe 45% with that, focusing mainly on the slope.
Okay. So I did the same thing what I did a open wedge flexionectomy with a differential opening and fixed with the staples. And I could get from -16 to +2. And so in small tibial slope corrections, we can do in coronal way, what Dinsha has showed in the morning. But large tibial slope corrections, either we can do distal to tibial tubercle with Elizarov, what Milan sir has said, but don't do it with plates. And this is the thing what we have done. And
Raghu,
This-
sometime, when you're using staples, because of this multiple holes, you may not get a hold in those staples. So I tend to use the lower end radius plate, the smaller plate with locking plates so that you can get a very stable fixation. Because here the whole fixation is only on the staples as well as on the tuberosity, which is crossing the fracture. Plus you're opening it. So there is a lengthening of the anterior.
that's why I was very specific about rehab.
Yeah.
Anyway, we are opening it.
Yes.
So there is tendency for the collapsing. So Dijor, he did long back. He never used staples. He got good results, even with staples. This was discussed by Dijor.
Yeah.
When you're opening, there's already in the compression phase. Whereas if you're doing closed wedge, it is more unstable. It requires more rigid fixation when you're doing anterior closed wedge. If you're opening, you can manage with staples.
There's only one thing I could have added. To fix the tuberosity, you can have the screws angling upwards posteriorly. That gives better cutout resistance rather than just perpendicular to bone, going up posteriorly. Anterior distal, posterior proximal, going up, fixing the tuberosity. But this is great.
I got this news 10 days back. It got accepted in the journal. Thanks for patienting all the parents. Now we'll go for the live surgery. And before going to live surgery, can you show the X-rays of pawning?
Thank you, panel members. Yeah. You are not excused. Thanks.
This is
for
the first
wonderfully
case.
conducting.
Bhushan, this is the first case. Bhushan, can you want to comment on this? Are you audible, Bhushan?
For the live surgery, may I now request Anshu Shekhar and Dr. Timma Reddy.
Hello, can you hear me, Raghu? Hello, hello.
Yeah, we can hear you.
Yeah, it's Bhushan here. Christian is just getting things ready. So,
Yeah, Bhushan, you have seen your X-ray, post-op X-ray?
yeah, so
Can you comment? First,
looks pretty good in my opinion. The plate position looks okay. That screw on the lateral side.
X-ray, yeah. Yeah.
We just stay here now.
Yeah, we can.
Guys,
Yes.
I'll do some X-ray now.
Yeah. This is the first case, morning, what Bhushan has done. So, you're happy, Bhushan? Okay. Second case, X-ray. X-ray, please. Second case, X-ray. What Dinsha has done it. Give the mic to the Dinsha.
Okay.
Dinsha, you can. This is your case.
Master,
Somashekar,
you stand here.
Mike. Somashekar, Mikey Chan.
All the stuff needs to come over here. Okay.
You can. comment.
Yes, I think basically what we wanted to achieve, I think we've achieved. If you see that slope out there, yeah, so that's that slope, and you'll note on the lateral X-ray that you're opening. Otherwise, normally what you'd see is that gap and that opening. You typically will see the posterior part will be, larger than the anterior one. And here you can see that it's more rectangular, or maybe the anterior is a little, I think that part is covered with the plate. But otherwise, this is, yeah, there's certainly an increase in the slope. If you could measure it, if you actually measure it, I think it'll probably be 12 or maybe 14 degrees of a posterior tibial slope. So certainly that slope's been increased. And if we get a weight-bearing standing X-ray, I think we'll find that that position is going to be much better. And the grade 2 PCL that this patient had, I think stability-wise also this patient is going to feel much better with this increased slope. More importantly, that mild varus which is there, we've offloaded it, but we've got a normal looking, I'm sure we require a full length tibia for that, but if we had to just assess the MPTA, I think we've probably got it to normal, yeah.
55%.
Absolutely, and I think that that joint line will probably be going through either the middle or the lateral tibial spine.
Extended.
Thanks. So we'll go for live surgery PPT. 50th years housewife, already one knee, she underwent surgery. Bhushan, how much time you want? Some more time?
We're ready for you.
Okay, just another 1 minute. So already she underwent surgery.
Let's draw the other one later.
Morning, what we were talking. So instead of a large correction, if you do there a single level, you can end up in 97 post-op MPTA. That's why we did a double level osteotomy.
Bit more upwards.
So this is now what you are planning to do on right knee now. Plan is to do a lateral closed wedge DFO with 7 mm and middle opening wedge HTO by 6 mm. Yeah, go to live, please. Thank you.
8, 7, 8.
Christian, you're on live. Christian.
Okay, perfect. So I don't know. I have a sore throat. Maybe you will not be able to hear me throughout the whole process. But let's just start. I made a drawing. I tend to do this to actually have a rough idea of the anatomy of the patient. So the fibular head is palpatable here. The distal femur we have here. This is the epicondyle. And what I usually do is I put the phalangeal part onto the condyle, roll down, grab over, and in between thumb and index, there is my approach. For the sake of this surgery, I will extend it a bit so that we have, well, I negotiated with Bush, and Bushmaster said, please do at least 8 centimeters. And so we have to do 8 centimeters. And this is now 8 centimeters. So let's do 8 centimeters to see more. And as you see, there is no tourniquet. I do all my osteotomies without tourniquet. The reason is, in case it starts bleeding, I want to see it. And then I know my enemy. So quite a good layer here, subcutaneous tissue. And now we go directly to the level of the IT. And in the anterior part of the IT band, we incise it to either side. So, and now from there on, take the bovie, and I used to do it with a bovie because I like to actually kill any eventual bleeders right up front. So I take now at this distal part where I am right now, here, I take my bovie now and form and transcribe a curve. So it's a J-curved incision that goes to the back to release the band to actually get access to the posterior part of the femur. And once we're here, we can already take this retractor to the front to lift up the vastus lateralis that you can see here. And now we are at the Kaplan fibers, which is this reverted part of the IT band. I hope that you can see this. Need to give me some feedback to this.
Yeah, we can see it, Christian. We see it.
Okay, suction here. And what you commonly have at this level is a lot of vessels. So this is why I do this with the blue Bovi button to cauterize those vessels directly. So, and now I'm at the femoral flare already to the back. And this is where you can we have another swap for the top area here just to drop the Bovi on it so that we don't burn through the drape. Perfect. So now you have this flare here, the posterior surrounding, posterolateral aspect of the femur. Come a bit further from here. Come here. Because then you can otherwise look around this corner. So sorry, we are readjusting the camera now. And I go to this very posterior edge and scratch at the posterior aspect of the femur. I free that from all adhesions. So once I've done that, I can stick my finger inside and have it now directly at the level of the notch. Okay? Do we need more light, guys? Can you readjust the light so that you see something? Oh, that's okay. That's okay. That's okay. So the next thing we do after we have access to it, I need a K-wire now in a wire driver. So let's put a 2 millimeter K-wire to it. The other way around. It's both. Oh, these K-wires are actually dangerous. Hold that please for me. These K-wires are quite dangerous because they sadly have a tip at either side.
So what do you maintain the blood pressure at if you're not using a tourniquet, Christian?
Just didn't
Patient's
get that.
blood pressure.
Blood pressure. 11466, the blood pressure just now. Oh, that's commonly something that you experience commonly because it's an area where do we have the Bovi? To which what is the? Put it to 70/70, please. Because the cautery doesn't do a lot here.
So do you desire hypotensive anesthesia since you're not using a tourniquet?
I'm happy. As long as I see the bleeders, everything is fine. I invest eventually some 2 minutes here to get this sorted. And obviously it works better when the Bovi is working. So we just relax now and it will stop. It will stop. And some 1 centimeter anterior to this, I will shoot my first K-wire into the blue, you know? I will just put it inside, as you can see. So please, guys, don't touch anything there. So we are way too low, as you can see. Give me the wire driver again.
Can we see the Siam picture also? We can't see the Siam now.
Oh, you will see that in a second. So let's have another X-ray. So I like the starting point, yet the end point to defy the hinge is not quite where we want it. So we take the same starting point, take the wire out and put it in again. And I would say that's quite nice. Yeah. So that is directly on top of the condyle. So let's take the next wire, please. Okay. And now we need actually something to measure our 7 millimeters. Okay. So you need to have something on your table which allows you to measure precisely 7 millimeters. And I know, but I cannot show you here, that actually this drill sleeve that I'm about to put here has nice little grooves. And if you put it to one side, then you find 180 degrees off from that on the other side, you will find another groove to align those wires nicely. And then these wires actually come in at precisely 7 millimeters. So let's see that we now form a nice little isosceles triangle. This one goes too low. Give me 1 second to readjust this. Yeah, coming closer, yet not there. That's not bad. So we leave it there. As you can see, there is like 0.5 millimeter in between those wires. Probably not enough for the saw blade to protrude through, but we want to be sure that that's not the case. So we take a 3rd wire and actually bring it here, okay? And to enable this, I just poke through the skin in between the level of the joint and the epicondyle, okay? Being there, I just take it. Want to have some proper grip at the bone. And once I find that grip, nope, we're too far away. That's it. So once I find that grip, sometimes you can just push it in, but here I ask push-on to just tap it in, as there is on the other side equally a sharp tip. And that's not something you want to push inside, I guess. At least not me. Okay, so you see, this stops our saw now, which is great. So let's have the. So I've defined my cage for my osteotomy wedge. You can see this here. And now what I'm doing is I need to define somewhat the osteotomy level. And I will actually be perpendicular to the posterior cortex that I find here. Take the retractor out. And I show you how to do and avoid saw blade in any diverted position. You want to see it exactly like this, where you see just the 1 millimeter thin line. So I have my hand, my finger in the back of the femur, and now I just drive in. Okay, I just fear that I actually put it into my hand because these K wires are actually, she's moving, isn't she? So you see, I'm now into the top of the contralateral condyle. So I now just take out this, take more of the vastus fibers, the whole muscle, perfect. So now I just put it to the other direction and see that I'm parallel. Let it run quickly, protect everything with my finger in the back. You will see this on the X-ray if I control it. Here's my finger, you can see my fingertip. So it protects the complete posterior surface. And I ride along to the contralateral aspect, which is here the medial side.
So what's the second best way to protect the neurovascular structures if one loves their finger too much?
Yeah, I rather cut into my finger than into the patient's popliteal artery. But the reason for doing this, actually, I can show you now outside. So if you take a look at the saw blade and my finger, then actually now you see the saw blade is running. And the technique is to just align your finger parallel to it and let it loose. And this way, you can do this for an hour and it will not hurt your finger. Okay? So that's by far the best retractor I've ever seen. If you have a very short finger, you need a shorter saw blade.
All right.
So this way around now our normal oblique cut is established. And now I palpate the biplanar. To do this, some 4 centimeters off from the initial osteotomy northwards, yeah, proximally, I just exit the femur. So my bovie is resting on the frontal cortex. And now from there on, I just incline to form a rectangular structure in between my initial cuts and the ascending cut, the biplanar. And this way around, I can equally check if my osteotomy has protruded far enough to the anterior part to actually have a complete cut. Okay? So now I take the saw again.
So what's the thickness of this biplanar? Is it 1/3,
It's
2/3?
1/3 till 1/4 of the whole femur. It's roughly 1/4. So the saw blade is swinging quite a lot. So you can go inside and then you align after you have your initial cut. You align it in a strictly frontal plane. And then you dive into the femur, making sure that you go from distally to proximally. And when you have a drive through, so meaning that you have proximally exited the femur, then you can go down again on the contralateral side. Then you have made the cut complete. So technically, after completion of this ascending biplanar cut, it should now be moving. And if I pull now, Bush is fixing the distal side. And if I just pull at this side, you see that the osteotomy opens. Can you see this?
Yeah, we can slide.
Okay, so let's now take something to harvest this little wedge. And we want to please keep this, so don't throw it in the bin, because that is something that we want to have to graft our tibia. Okay, so now I need a needle holder, please, just to extract the inferior wire, or I take this one that works equally, obviously. One fewer risk of injury because one wire is out. So, and now we could gradually try to close this. And I don't want the distal side to actually manipulate on the foot to close it. They shall just hold it there, and I can gently push against the knee. I just gently push against the knee. Sometimes I push against the wire, but here, as it's a sharp tip, I will not do this. So I gently push, and it closes, yet it doesn't close completely. So I take the saw now again, please. And it may not close because there might be some remnants inside still. So I just repeat my process. Okay, you can take out the retractor, please. This is now an X-ray controlled thing. This is a level somewhat after half the osteotomy. This is a level where I cannot go further with my saw. So meaning this is actually obstructed by some remnants that are still inside. And so I recut this area just by gently sneaking to the hinge, protecting everything in the back, pushing the knee to the medial side. And once it's there, it should be basically stopped by the hinge wire. So now from that hinge point on, I can go in, out, in, out, in, out, in, out, and gradually close the osteotomy by with a constant push from the lateral side. So if we now do the same again and check our remnants and apply some suction now. So you see the osteotomy is completely closed. Open.
Christian, there's a lot of blood. We can't see that.
Okay, open.
Give it, yeah.
Closed. Hold it. Open, closed. We should not do this too often because then it's after osteotomy open and closed 20 times, there comes a fracture hinge. So this is why we leave it now that way. Remove the other K-wire, perform an X-ray control, and here you see complete contact at the. Okay?
Yeah, great. Yes.
Our other K-wire remains in place. Now we just take the plate, which is one. There's quite a kink now at this flare of the lateral epicondyle. It'll be probably tough to align it. Next K-wire, please. To align it a way that you don't have a gap underneath the plate. So probably it will. Yeah. Can you adjust this longer? As long as you can, because the K-wires are short. So, but maybe we can manage. We will see. So this is now a rough assessment, and once again, controlled. So this is quite low. It's higher than on the contralateral side, where she already had an osteotomy. But as it's low, we could potentially go 2 millimeters higher. So let's just play with this and go 2 millimeters higher and reinsert it. So the plate on the bone. I think that's nice. So the epicondyle is roughly there. The proximal, maybe even 1 millimeter more, and then we're there. Just to give the epicondyle enough air to breathe. That's probably it. Okay. So, and as this is now done, we go to the proximal part of the insert the next drill sleeve. We just need to come here. Don't pull too harsh because then yeah, that's it. Now give me the screwdriver. There is a fancy tool here. Oh, no, it's not. It's not the new version. Okay, will not work. Yeah, I just fear to come closer because eventually this K-wire will finally be in my hand. I'm not interested in that. So can I have a needle holder? Needle holder, please. Now it's in. Okay. Okay. So now we take the next sleeve limiter. So there is this tube for the sleeve, and we put that inside. Thank you so much for protecting this one. Let's take this out. Now, once again, the foot is just held in position. I take the next K-wire now, please, and the wire driver. And now I can toggle around this distal fixation point. Can you see this?
Yes, we can. Yes.
Okay, so this is to align my plate now to the shaft of the femur. This is too far in the back. This is too far in the front. This is too far in the back. This is too far in the front. That's somewhere in the middle. Okay? So under complete closure, pushing the knee to the medial side, I now try to fix the plate or transfix it temporarily. So let's go a bit northwards, please. Yeah, pull, yeah.
So when you were firing this wire, the osteotomy was kept closed, correct?
Yes. So this is, I mean, if you now have a gap of 1 millimeter, don't be too concerned because this gap of 1 millimeter actually will close when you yeah. So what we now do is a lateral X-ray. So I would now do a lateral X-ray. But it's tricky to do it here now, isn't it? Can we do it? Do you think we can do it? Let's do a lateral X-ray to show them. Okay. So let's have a drape, and then we swing this one through. Wait, the stool has to go. Okay. Yes, please go through.
Christian, can you show us the biplanar cut by the time the C-arm is coming?
I will, but now in this situation, it's tough.
Okay.
Give me a second, please. Let me rotate it away. You can see the biplane. You can see it there. Can you see it? This is actually looking into the biplane. But you see one other problem. You need to have a lateral view because the distal side is too far of the plate, is too far posterior. So we once again need the wire driver. And as we have fixed it in the end, in the proximal part quite nicely, Bush, can you just, no, don't open it, close it, compress it, press against the foot, lean against it. Yeah. That's it. So now I just, as we are too posterior here, I just extract it, go a bit anterior, and push it back in. As simple as that. And it's a very calm situation where you can do this. The X-ray is doing actually nothing. Here we see it. Can you see it?
Yes, we can. Yes, it's
the position of the plate is actually ideal. If I'd be rotating further, you will not see the biplane because then the plate covers it. But that's actually very nice. So we go back to AP position, please.
Anshu, one question.
We have a question from the floor, Christian.
Christian, if you got a varus which is isolated in the femur, how much you will correct in the femur? Is there any limit up to which you can go 7, 8, 9, 10?
No, I mean, I've done correction in the femur 14 millimeters. I mean, these are raw cases. I mean, you really don't see this very often, but you need to just follow anatomy. Usually those cases are post-traumatic cases and stuff.
Thank you.
Yeah.
Welcome. And would it lead to joint line obliquity as well if you're going like a larger correction isolated in the femur, like the concept we are having a double level osteotomy for varus in the tibia? Similarly, if there is varus in the femur, so when you will consider a double level osteotomy to avoid the joint line obliquity while you're opening two.
Sorry, I didn't get that. Is this a question for me?
Yeah.
Okay, so you have to repeat this because I wasn't following.
So if you're going for a larger correction that is around 12 millimeter or 13 millimeter in the femur, so would you be concerned about the joint line obliquity again?
No, because actually you plan this correction to make the joint line right.
Yeah.
I mean, you only do this if the joint line actually asks you to do this. In cases where you have an MLDFA which is completely off. Yeah. So if you have planned an osteotomy which is about this, an osteotomy which is about this high, or a correction which is about this high, then this is for a meaning. So you should be concerned about the actual state the patient finds himself in. That is rather an issue. Okay, let's take now the initial screws that we have, and we have these these ones here. We take these two ones now.
Christian, could you ask the camera person to maybe go to your right shoulder? We can only see the back of your neck now.
Oh, so sorry. Oh, so sorry.
Camera person?
So just report when we are making nonsense, because we don't see this here. Number 1 and number 2. Yes, give it to me. That's okay. So she's not very tall. So we decided initially already to do the proximal ones here, the anterior screws, length 50. Probably that is sufficient. Let's measure the posterior ones then. But I wanted to have a quick process, and out of experience, this is somewhat a good length for her, I assume, and as you can see. So we are crossing our osteotomy with the proximal screw. Can you see this?
Yes, we can. Yes.
I don't mind at all. I don't mind at all, because there is like 3.5 screws still there. Everything is fine, and this is the most proximal screw. Once again, can we apply some suction here? So if you take a look at the configuration of the plate, see this?
Yes.
So then there is actually, this screw is surpassing a bit. This one is not anymore, and this is the most proximal one. So these are actually not all parallel, they are stacked. So this way around, we can make sure that the others will be completely in the distal part, okay? Give me the wire driver, please. Once again, I need to, yeah, we take out this little fella now. Perfect, thank you so much.
Do you want to complete your fixation distally and then?
I will now distally complete my fixation. So we need the drill, please, again. And now please open another 60 millimeter screw. Another 60 millimeter screw. Yeah, another 2.
And what's preventing any inadvertent opening of that correction that you have done?
Say it again.
So what is there some maneuver that you're doing which is preventing that osteotomy from opening by even a millimeter now?
Yeah, there is a maneuver, and that is the transfixation with the proximal K-wire. So it cannot open. It's fixed at the distal side, and it's fixed at the proximal side.
I'm leaning with all my
and we have, yeah, this is, the question is actually great, because the position of the patient is so that the foot actually leans some 5 centimeters over the distal edge of the table. So, and we call this the belly press technique. So the assistant is actually pushing against the sole of the patient to reduce the osteotomy and close that. Can we zoom out to show this?
Exactly, yes.
Just show the foot. Just show the foot. So that is the belly press technique. Make sure, in every case, make sure that you have an assistant with a belly. Otherwise, this doesn't work, huh? Bushan, I just wanted to thank you so much for this. Okay, now, as we have fixed it there and it's still transfixed here, we take the other drill, please, the narrower drill. So there is another drill now, 3.5 mils, not 4. Just change the drill.
Yes. So what are you doing now exactly?
Well, we now apply a compression screw. So this screw is decentered. There is an oblong hole here.
Can you show that hole, Christian? We can't.
Yeah. Let's.
This is important.
Let's make sure that you see this hole. So this hole is actually oval. It's an oblong hole.
Right. Yes.
And this is a device that decenters the screw in this hole. Okay?
Right.
Now it is decentered. It's not really, it's reaming. It's constantly on reaming us. So this is now a screw length of, can you read this off? 35. 35? 32. So we measured 32 plus the cortex on the other side, another 3 mils, which is 35. And as we are lazy, we don't measure this. We have the gray screw now, one of the gray screws in 35, please. So still, nothing is happening here. It's transfixed at the proximal side. It's actually finally fixed at the distal side. I can put my finger here and feel that everything is in order. And I can once again confirm closure with an X-ray. Can you see this?
Yes, we can. Yes.
Okay, so I'm happy with this. And what I'm most happy with is that the one screw that surpasses the osteotomy gap actually hides everything. So you cannot witness whether I've closed the osteotomy or not.
All right.
Just have to believe me. That's smart, isn't it? So now we take the gray screw.
Christian, can you show this screw how it's different from the other blue screws?
Yeah. This is just is a very, very simple thing, actually. This is obviously the normal blue screw, which is angular stable screw with a thread at the head. This one doesn't have that, and it's a cortical design that goes to the contralateral cortex now and actually grabs there and compresses. And we just insert this now to make this happen. And we drive and approximate the screw to the plate. But we must not now pull it really onto it, because what happens then is that we compress against our transfixation. So now I give myself the freedom of movement by just extracting and taking out this sleeve limiter. And I therefore have 1 millimeter of compression distance, exactly the strength of the material, 1 millimeter either side.
Okay. Right.
So now I compressed it, and technically now I can remove the last. Give me the wire driver, please, again, or the needle holder. Give me the needle holder. That goes quicker. No, to give me the wire driver, probably.
Now your wire appears off center in that sleeve.
Right. So where you can see this really, that the wire is decentered in the hole. Very good aspect. So now I take the wire out, and actually now I'm happy first time, because now I cannot injure myself anymore. Okay. Now this persisting sleeve acts like a retractor, holds the approach open, and I insert now from this side. Give me the drill again. Drill again. Yeah, sorry, we have to change the drill.
So you have 4 screws distally and you'll be putting 4 proximally, correct?
And I will be putting 5 proximally, because it's 4 angular stable ones and one
was the compression.
Is the compression screw. What do you measure here? 65. So this is the short drill in the long sleeves. So we measure 65, actually is 35. Okay? So we take 2 40 millimeter screws, please. 40. If they are 3 millimeters too long, I don't mind. They come in 5 millimeter increments anyhow, so it's not really decisive here. So we take two 40 millimeter screws. That's 30, huh? Yeah. We take, well, give me the drill again if we still
You
have.
want these to be bicortical or you believe in the unicortical?
Yeah, good point. I gonna do the two ones in neighborhood to the osteotomy. They go bicortical. These two proximal ones, I just do go for monocortical fixation. So make sure that the proximal ones are short. You don't necessarily need to go for a bicortical fixation here. But I like to have a monocortical fixation. In fact, to have a second line of defense when things go wrong. I want some other cortex that I can still aim for. Okay, let's have the other screw. Where do we stand when it comes to timing, guys? How much time do we have left?
You have about 25 minutes.
Okay, let's speed up things. Okay, now we take the two 30 millimeter screws, please, that we have there. Give me the needle holder. Pass the needle holder to Bush. Bushmaster will remove the hinge wire. Nice one. And now give me the last screw, 30 mils.
Are you planning to replace the hinge wire with a hinge screw here?
Nope. Because in this case, I'm just completely satisfied with my hinge. I only tend to do this when I'm not. So let's make some X-ray. So these are too long. I don't like those ones. Let's remove these ones and give me two 35 millimeter screws, please. Let's 40. Let's use them then for the tibia probably. Cannot get this one out. Okay, two screws 35, please. Yeah, let's just redo this. So we cannot measure here properly. As I told you, we just had to assess it because we don't have a long drill. That was the problem. We just have a short drill and kind of, yeah, anticipated how long these might be. So as I told you, I don't mind if they are too long, but if they are too long, then we actually have to do something about it.
So while you're doing this, Christian, can you ask the image intensifier guy to show us a lateral view?
Yeah, I could. Let's do this at the end for the sake of timing, okay? Or maybe at the very end, because I otherwise have issues finishing off with the tibia. And there is some interesting aspects about the tibia. I need a new glove in a bit. Okay, let's do another X-ray, AP. That's better. So you see that even the 30 millimeter screws in the proximal aspect are quite long. They are monocortical, yet they are longer than they have to be, but I don't have shorter screws here. So, but what you can see on this X-ray is you can see, in fact, the anterior osteotomy, the biplanar, because you see at the distal aspect some whitish area where the ascending goes northwards. Anyhow, I will show this to you later. So let's do some closure after we've done this. The next thing now is actually let's move the intensifier to the other side. We have to shift the intensifier now. Whilst we do this, I can already close here. Yeah, go to the other side. Come out. Let's have the first suture, please. Okay, time for questions, guys. There is 5 boring minutes now, and then we
can have questions from the floor if anybody has any doubts. People are stunned by your performance, Christian.
Yeah, no, it's actually it follows a certain principle and technique. So there is nothing crazy about this, and this is actually learnable and doable. So I would say first thing is to master the HTO. And once you master this, well, do plenty of HTOs, of DFOs exactly this way. And you will see that it's not very difficult. It's technically first at hand, obviously, something where you would consider this to be challenging, but in fact it's not too much. So now we just close the IT band, and we have somewhat excised it here. That's nice.
Yeah, this was a
Wait.
horizontal cut on the IT band. So you would close it completely, correct?
Yeah, I will show you. So what we now do is we just approximate it here. So, and then there is actually two aspects to it. There is this cut to this J-curve cut to the posterior side. Yeah.
Yeah.
So we have to close that. And that is done with a couple of stitches here.
Do you use something for hemostasis like tranexamic acid or?
Yeah, I usually inject TA. That's what I do locally. I don't use it systemically anymore, because if you compare statistically what it delivers in terms of hemostasis, then the local application is obviously weaker than systemic and local. But if you compare local application alone versus systemic application alone, then the local application is way more powerful. So, which is good enough for me then. I can easily get away with this, and then I don't have to justify that I use it in a systemic approach and have to discuss this with my anesthetist. And that saves me 5 minutes of discussion time. And in these 5 minutes, you can do another surgery. So probably it's wise not to discuss this. So now, where do we stand when it comes to the intensifier? We have the position checked. Okay, the scissors, please. Nice one. So IT band is closed. Intensifier for us. Okay, so this is why we have to change our position now. Good. So that was the DFO, lateral closed DFO. So now let's come to this side here, and obviously we need to shift the lights.
Anshu, may I have an Anshu, may I ask some question?
Yeah, please, yes.
Adrian, we find sometimes in some of our Indian patients, especially females who are short, this plate, the anteroposterior part is too broad. I mean, you know, you can't.
Should I tell you something? I completely get your question, because this is exactly the patient that we operate here that you were asking about. So this was exactly our challenge here, and this is why I shifted the northwards. Lights to this side, please. But it's still, when you take all these distal femoral plates, and I can tell you I've used them all, this is still the smallest that we have. The new plate that actually was designed initially for rotation osteotomies, you've seen this today already in one of Ronald's lectures, is actually a bit smaller. So maybe this would be the better plate for you sooner then.
Thank you.
You're welcome.
What are your indications for PSI in these DFOs?
Yeah, I don't have any, because I was trained like this. It would be, I can tell you, personally, I don't have any, but it would be multiplanar post-traumatic corrections, for example. These are cases where you, without vast experience, are somewhat lost. And I would say that's a good, you're well advised to do your practice and change your practice to a PSI that could help you out. So now this is the joint level. See this? Or Bush, are you? Let's rather come from here with the camera, because there you see way more. So guys, sorry, we have to readjust the camera now. Camera position. Come out of it. Come out of it. Otherwise. Okay. Well, a bit northwards, further northwards. And same thing. You just go up, 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 up. You have to come out first. It doesn't. I'll just come out. It's okay. You can stay there. That's okay. Okay, so are you there with us again? Do you see everything?
Yes. Yeah, we can see now. Yeah, this is better, yes.
Perfect. So where's the needle holder? So there is a trick when you, no, there's not a needle holder. That's some device that we don't need. So when your surgical marker is not working anymore, just pull it out and then you have a new one, okay? So this is the tibial tubercle. This is the posterior medial aspect, okay? So this is actually the center of it. And I usually cut like 2 centimeters below joint level. So from here to here, yeah? In this case, I will cut from here to there, okay? Is that okay? 7 centimeters. Let's not go for 8, let's do 7 here. It's a tiny plate. We have to close it. Someone has to do the work. So we just go inside, and this is blunt preparation, as you can see. I just take my fingers and prep the tibia here, okay? And I prep it till you see the fascia. Can you see this?
Yes, we can.
The next thing is we have another lung back, please. Take the short one, not these long ones. These long ones really ugly. Okay, so this is the tibial tubercle. You can see this here. And there is this ridge commonly, this ridge where the tibial tubercle can be palpated. Let's burn these bleeders. So what I now do is I take the tip of my bovie and dive in behind my patellar tendon and just follow this ridge. See this?
Yes, yes, we can.
That's my biplanar. Okay, just to know where it is. There is no issue with this. So this is the anterior border of all my action, obviously now. Now I take a curved clip and the forceps and palpate, suction please, the hamstrings. This is the pes tendons. So now I dive behind the pes tendons and clip. After I've done this,
Your hand is coming in between. This is an important step. Could you just show it again?
yes. So lift up the pes, take the curved clip, dive in, and once you're in this bursa, you just open it, and by blunt dissection, it's automatically retracted. So now this retractor comes here, and we release the tendons in alignment with the tendons. So we don't detach them, we just release them. So we see the complete surrounding medial collateral ligament. And in fact, now here, we are in the back of the tibia, okay? So like in the femur, I now can take a periosteal elevator and palpate the back of the tibia. And now you could hear the scratching. Can you hear this?
Yes, yes, we can.
So I scratch the back of the tibia and go all the way to the contralateral side. In fact, I'm now touching the fibula. I'm going to the tib fib, okay?
Right.
And I go back a bit northwards and southwards once again to release this to an extent that allows me to put my finger inside. And now I'm just having my finger in the back of the tibia. Can you see this?
Yes, we can.
Okay, so all the rest here anterior to it is MCL. That is MCL.
Right.
Okay. So I can palpate actually the head of the fibula from here. And this is why I know where the K-wire needs to be inserted. So I actually now make some space. You don't have to pull that there. And go to the front, maybe yes, because otherwise they don't see it. And go to the front of the medial collateral and drive under it, just to elevate it from the bone. Can you see this?
Yes, we can.
Okay, so this is now just a release, not really the medial collateral ligament. It's actually, once again, the fascia. So, and here I've elevated it now to a point where I could insert a Hohmann retractor. Do we have this Hohmann retractor? The tiny one. Give me the smallest one. No, this one. Hold it here.
What if we horizontally transect this MCL at this stage?
No, I don't transect it. I just want to release it to here. Okay?
Is there a problem if that is done? If it's completely chopped off?
No, it's not. There is no problem. You can actually dissect it. I just don't like it. There is no problem with this. So give me
Right.
the translucent retractor. So usually I take my finger actually now and put it to the back. So actually where I had it already, yeah, palpate it and put it here. The problem is if my hand is here, you will not see anything, okay? Let's take this retractor here for my finger. And now we take the first K-wire and just drive it inside. The wire driver is now connected. Yeah. Okay, so usually with this plate, we can be quite high. So it's not really at the level that you see here of the pes tendons. It's rather here. Revert the, put your K-wire and you just drive in approximately to the direction that's just now palpated where the tip of the fibula is. Okay, so now we come here, come a bit downwards, take this one off. Now I need some space here. Yeah, that's it. That's nice. Completely off. Give this to me. But the starting.
We have the Siam picture as well.
Wait a second. That's it.
Yeah.
These K-wires are actually really dangerous. So make sure that you don't have these. Otherwise, you will hurt yourself every now and then. I don't understand the concept of the product. So as you see now, we've seen other osteotomies. I like to be really at the tip of the fibula, like shoot the head off the head. That's the idea behind it, okay? That is where I want to be at. And what we now do is we just perform our cut. So can we have that's perfect. So, and we do this in alignment with the slope. Now I just check, sorry, Bush, that we see the subchondral sclerosis as one line. We have this here. And then we align the saw blade, take the retractor out once again. So, and angulate this one, only this one. The posterior one can stay because that's translucent, perfect. And now we align the saw blade like we did in the femur. Can see that?
Yes, we can, yes.
Okay. So now, the first thing that we tackle now, can we have some suction here so that they may see something? So this retractor that Bushan is holding here, put that one inside, that's nice. So this Hohmann retractor is actually exposing the posterior medial border of the tibia. Can you see this?
Yes, we can, yes.
So that is the first area we tackle. I just follow this till I have a rendezvous with the posterior retractor. So that way around, I know that I've cut the complete tibia and the posterior medial aspect, right?
Okay.
So then I go to the front and I've actually marked out the ascending part, okay? Now, just check to where we can protrude, not to damage our hinge. We're here. Can you see the saw blade?
Yes, yes, we can. Yes.
So we are like probably 3 millimeters away from the cortex.
Do you normally like to go that far?
Yes. So the best way of avoiding to create a Takeuchi 2 or 3 fracture is to create a 1 yourself. So on a micro scale, if you CT those patients at the very end, this is anterior. I'm going purely anterior now on purpose. So I left the posterior structures intact and I diverted my saw blade to the front by pushing a bit to the back. See that?
Yes.
So I'm actually exiting now on the other side of the tibial tubercle. And I can palpate with my index that I'm at the tubercle here, okay? So now I just want to make sure that I've cut the whole posterior cortex of the, can I have the ruler, the metal ruler here? Posterior cortex of the tibia. And I do this, now I hurt myself here. something that I've expected. I need a new glove.
You can cut the tip of that K wire. You know?
Yeah, it's really nasty. So give me the saw again. There is this very edge still there. Hold this down here for me. Perfect. Can we have some suction, please?
Christian, there's a question about hinge wire. When are you going to place your hinge wire?
Yeah, I will answer this. Actually, I sometimes do it prior to this. Sometimes I don't. Just need suction. Just need suction, guys. Wait, give me 1 second. I just need to perform this cut first. Okay, now this is cut. So sometimes I do it before, sometimes after this cut, because right now, nothing will happen at the hinge side. I don't take this K-wire as protection for protrusion through to this aspect. So if you look at the X-ray now, obviously I could take it as a protection at this side, but I don't want to, because you've seen that in the anterior aspect, I actually on purpose take my saw blade and drive further. Okay, so you could protect it there, but I don't tend to do it. But yet I have still not cut the biplanar. So now having the fibular head here, Gerdy's tubercle here, and the joint level there.
Can we zoom out a bit? Can we zoom out a bit to see the hinge wire placement?
Yeah. So here we have the fibular head. Here we have Gerdy's tubercle. Here there is the level of the joint. So we go inside, place this there, and you tap it down, please. On, yeah.
So you never place your hinge wires on power?
Well, sometimes yes, mostly not. Sometimes you can just poke them in with your manually. So now we remove this one, and the MCL should technically just go back to where it came from. We bend this a bit out of the way. I don't do this usually. I just do it here because I still fear the tip. And now we perform the biplane. So the osteotomy, in fact, went to here, and the biplane is here. So we precisely mark out where our biplane has to be. Oh, that's okay.
You don't want to protect your patellar tendon with any retractor at this stage?
No, because I see it in front of everything. So now I can open the osteotomy already a bit. Can you see this?
Yes, yes.
Actually pumping there, yeah?
Yeah.
Right? Okay, now what I usually do, I don't know if it works here, we will see. I take a forceps. And actually I take the forceps and put it posterior to the medial collateral ligament in the osteotomy gap. Can you see this? So the MCL is actually in front of the spreader now. Yes?
Yes.
Okay. So let's have a mallet, please. Now I take this forceps, and the only thing we do now is we measure at what level we reach the width of 8 millimeters. That would be here. So it's really the middle where it's thickest. So now I just gradually tap this in, and this acts as a wedge. This is actually the opening wedge for my osteotomy, okay?
Why not use a laminar spreader here?
Well, because the laminar spreader is hard to be put inside, and actually I like to have wedges. And the next thing is I had to have many tools at my table. And so when you finally are at the point where you can perform the surgery with a blade and a forceps and probably a pair of scissors, then it becomes very, very, very easy to get it done. So once again, you see, we are now there, open tent, not bad at all. So we can remove this one, I guess. That will not do us any favor. Okay, so we look at this now, And I would say it's time to perform a control of the alignment. Set the alignment rod, please.
So what plate are you planning here? A size 1 or a size 2 plate?
I take a small plate for her. She's, as you mentioned already, it's sometimes hard with these patients because some are tiny, and she is, and it's actually very, very difficult in her to place huge plates and unnecessary. Let's come to, yeah, you need to come out there now. No, just come out. That's okay. Make yourself unsterile. There's no problem.
So is there like a BMI cutoff where you would not use a size 1 plate?
No, actually not. Okay, so come northwards, all the way up. That's nice. Just stay away. That's okay. Just stay away. So that's nice. Now let's come to the ankle joint. Please come down here. Yeah. Okay. Yeah. Yep, that's okay. And now come to the knee, please. I lose my voice here.
So no tummy foot compression maneuver here?
So we could go a millimeter more probably, but I have not simulated any weight. I'm doing this now. I'm leaning against it.
Yeah.
I think it's okay. It's the lateral tip of the lateral spine. So when I lean against it, it does this. And if I release, it does this.
Correct.
See, it lifts from
Yes.
here to there.
Yes.
Okay.
Right.
So I'm actually quite happy with this position. So now let's just take some, let's take the bone. So we have the bone now here. So we open this gap. And the great thing is that you can see all the medial collateral ligament is still there. It's all here. Yeah. So if this is now tense, and this is probably the case, I just take a blade. Give me a tiny one, not the big one. Give me the small blade.
So the pes is under the lung and back, correct?
Right. And now I trepanate the medial collateral
Cameraman, focus,
ligament.
please. Yeah.
I just pie crossed it. So we can hear the crack of the fibers. You can't. But as the MCL is now in front of the spreader of my wedge, which actually is a forceps, you cannot change the slope in terms of increasing it. Actually, you must maintain the slope this way. The problem, as Adrian said, always has been when you have a tight structure and you open in front of this, then actually you cannot open it properly. So now let's come here. Let's put this one back. It's nice. And now we just tap this one in. It's a very, very sophisticated tool we're having here.
What's that you're inserting now, Christian?
Well, this is the wedge that we have from the femur. And
So
as
you're
we cut out
putting it anteriorly.
7 mils, it should be -2 because we had 2 sides of a cut, leaving us with 5. And we are inserting it in the anterior aspect where the osteotomy probably is not way bigger than. Give me this impactor again. There is some edge still. Yeah, and the mallet, please.
Christian, could you show us the tension in the MCL now? Just wipe off some of the blood and show us how the MCL is.
In extension by the hamstrings, but I show it's here. Can you see this?
Cameraman, focus. Yeah.
Can you see it?
Yeah. Yes. Yes. Yes.
Okay. So if you would go to flexion, you can see it easily. Okay.
Right.
So because there you can revert the hamstrings. In this position, it's not that easy. So now let's take another time the K-wire, please. Wire driver with K-wire. And now we just position our fixation device. And let's just see where we are. Let's check the height. Come southwards a bit, please. Just move the intensifier a bit towards us. That's not bad at all. Okay, let's take the drill, please. Okay, now we position the posterior plate, which is probably some 40 mils. Yeah, give me a 40 millimeter screw. Yeah, 40, give me this one, 45 is okay. We've had those ones here. Give me that one, that screw. That's nice. So we position the first screw now. And now let's check interior screw insertion. Well, we're not quite there. We have to move out a bit. Out, 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 further, 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 further. Yep, okay. Now rotate again. Rotate the wire, the wheels and open this. That's nice. Okay, so let's insert another drill sleeve. Where's the short drill sleeve? So, well, give me the doesn't matter. Give me this one. Short drill sleeve is here at the table. We just remove. It's really dangerous, isn't it? Give the wire driver. Nice. Good job. Okay, let's drill. Okay. Where are we at? 60.
Can we see the Siam picture also as a PIP?
Sorry.
Yeah, yes, great.
I thought you'd be seeing it. Give me a 60 millimeter screw probably now. Yeah. Let's use that one for here. We take a 60.
Can you please ask Christian about now the role of either not releasing or releasing MCL? It was believed that it will increase pressure in the medial joint.
Yeah, Christian.
Please.
Christian, can you hear me? Yeah. So we have a question from Dr. Milind Chaudhary about your understanding of releasing or not releasing the MCL. How much, how, and when should you be conservative? When you should be more aggressive?
Well, obviously, if you don't release the MCL, you raise the load in the medial compartment. But this is actually why we pike crusted it. And so I have not fixed it yet, but I will show you after fixation that actually you can speak to your medial collateral ligament and ask how tight it is. This is why we pike crusted it and palpated it. Okay, so and by palpating your medial collateral ligament, you can ask it, and then it tells you, "Oh, I'm tight," or it tells you, "I'm okay." So, and we asked it, and it told us initially, "I'm quite tight," and now it tells us it's quite okay. Where are we at, Bush? We cannot read off the calibration because it's 35. No, it can't be 35. 45.
When does he like to reattach the MCL? Are there instances, does he like to reattach to the plate rather than pie crusting?
So
Has he ever
Christian-
used a suture
Christian-
anchor?
Yes, give me a.
Yeah, so the question is, would you at any point of time reattach that released MCL?
No, because it's not. It's actually released but not detached, so there is nothing to reattach.
Okay, if someone were to, for example, how Ronald does it, he completely detaches it distally, right?
Yeah, then you can just leave it. There is no point. There is no point in 45, please. There is no point in reattaching it. At least if you have not. Yeah, but this is drilled already. 45, please. And if you have not, wait 1 second. Give me 1 more second. What do you read of there?
Have you ever experienced MCL instability after an HTO?
Yeah,
wedge?
that's what I want. Let me just do this last drilling. So the thing is, if you, was somebody about to answer that question? Oh, so if you detach it too high, yeah, then actually you obviously run into like a normal sleeve release for a total knee. 35 now, please. Yes. Then you run into issues. But if you don't detach it that high, then any detachment at the level of osteotomy here will not cause any problem.
So how high is too high?
Well, how high is too high is anything above 3.5 centimeters proximal to the joint line. So I would say that obviously cannot stand as a golden figure because there is patients like her who are very small. Probably here 3 centimeters would be sufficient of remaining attachment. In other chaps like Adrian, I would probably rather like 4. So it's like everywhere. If you give measurements in metrics, then that cannot apply to patients of all height. I never understood the concept of TTTG actually, because there needs to be a ratio and not a definitive figure. So this is like the osteotomy now, and you see it's completely filled with the little of what we harvested at the femur. We actually have our alignment nicely on the well, in the center, I would say. And if you load it on the lateral spine, this is now the position of the tibial plate. And now and you see even the tiny plate in her is quite big. So now let's go for a last lateral view because you asked for it and you don't have to see the closure. That's rubbish.
Yeah, we apologize for you to having make such liberal incisions today.
Yeah. Yeah, this is actually really a problem because now we have to invest lots of time into the closure. So you caused us really issues. This is like scratching the surface there at the back, but that's okay. I still leave it. And now let's go for the femur, please. A bit further northwards. That's it. Now you can come down a bit. So you see that is the alignment for the femur.
The femur looks good.
Plate is nicely aligned. And let me rotate it for you. There we come into the aspect of the biplane. Can you see the biplane?
Yes, we can.
The biplane is just a 1/10 of a millimeter, I would say. And the posterior aspect of the femur is you cannot see the osteotomy.
Can you show us the slope, Christian? Sorry for that, but
no issues. No issues. Come down here. I mean, at least I need to witness now that I told you cannot change the slope in such a scenario. Is that okay?
So you're happy with this slope?
Actually, I am. So it's obviously it's rather neutral. So it's 70.
Christine, can I ask a question, please? Hello?
Yes, can you hear me?
Yes, we can.
Sometimes I just hear me here inside the room without any feedback, like echoes from the audience, and then I constantly think that nobody hears me. So
No.
I was asking a question. What precautions did you take to make sure that the posterior slope was not altered, the posterior tibial slope?
Well, it's actually an inherent thing. So that is basically built within the technique, because when your spreading device is posterior to the medial collateral ligament, you cannot increase the slope. It's technically not possible, but you can decrease it. So you could actually extend the limb. But then you still see, obviously, if you have opened in the front, like probably 2/3 of your estimated osteotomy height. And in this case, well, this is what you normally have, like 2/3 of your osteotomy height posterior. So I expect in an opening of 7-8 millimeters, some 5 millimeters opening in the front. And this is what we have seen. And this is where we impacted our 5 millimeter wedge base height that we have obtained from the femur. Because there we have had a cutout of 7 mils, minus 2 millimeters saw blade thickness at either side. So we had a wedge of 5 millimeters to insert. And this is what we inserted without any chamfering in the anterior aspect. So our HTO anteriorly was 5 mils. So I expect it to be 8 in the back as planned, and that actually contributes to the planning and to the result. So I would say we were quite right here.
So when you're spreading, you spread it more posteriorly.
Only the wedge, meaning the forceps, was only in the very, very posterior aspect of the cortex. It was posterior to the medial collateral ligament.
Right. Okay.
And that is actually an advantage, because there you have the medial collateral ligament right in front of you. In the back, you have the forceps. Then there comes the medial collateral ligament. And after the ligament, you see the opening of the anterior third of the osteotomy. So you see the whole MCL in front of you and know whether it's tight or not, because you can take your finger and put it on it.
Right. Thank you.
Thank you. Thank you, Christian. So I think we'll sign off from here. Great surgery as usual.
Thanks,
you very
Christian.
much.
Thanks,
Thank you,
Anshu.
Bhushan.
Thanks, Timareddy. Thanks, Anshu.
Thanks to the team.
Guys, we'll have the workshop starting at 6 o'clock.
Wait, just want to say.
And hope you can join us in morning walk at 6 o'clock.
They just shut me off.
Join the banquet at 7:30.
Nasty.
Pool sites.
Guys, anyhow.
We'll go for workshops.
Yeah, of course.
Thank you, Anshu and Timareddy, for moderating.
Thank you.
Yes, sir. It's a workshop. Sir, we want the workshop. Just in front of there only. So, actually,